So are we good to go now?
We are good to go. We have a couple
Oh,
people still joining in, so if you want to give it 1 or 2 more seconds for them
yeah,
to make sure
good.
their audio is good.
All right. Well, thank you everyone so much for joining us today. I'm Alex King. I'm one of the nurse practitioners here with the UVA Movement Disorder Group and help direct our MSA center here along with Dr. Shah. And as part of our new designation as a Center of Excellence, we are putting together this webinar and conference to talk more about multiple systems atrophy with our excellent presenters today here. And wanted to say thank you for our presenters and also all of you for taking time out of your day to come listen to us. And thank you very much for Mission MSA as well for helping us put this together and get the word out. And thank you to Peter, who is our AV expert, who is helping run our Zoom today. So we've got 5 presenters, and we'll have time for Q&As at the very end. There may be some time in between panelists, but if not, we can hold the questions until the end, and we'll get to them. You can also type them in the chat throughout the presentations as well. But that is all I have to say, and Dr. Shah may have wanted to say a few words, but he is finishing up in clinic, so he may be just a couple seconds behind. But if not, we can go ahead and get started with Dr. Figari, who will give us an excellent introduction on multiple systems atrophy.
Thank you, Alex. Welcome everybody. My name is Renzo Figari. I'm one of the movement disorder neurologists at the University of Virginia. And I'm going to be going a little bit of an overview of multiple system atrophy, mainly focused on what we define or diagnose multiple system atrophy, what are the diagnostic tests that we have. And then we're going to see with all the other panelists later today. There's other people talking about more about the management of multiple system atrophy or MSA. So whenever we see a patient with what we define as a Parkinsonism, we have to in some way put it within these 3 different buckets of diagnosis. We have the patients who are presenting with what we call the typical Parkinsonism, which is your classic Parkinson's disease proper. Then we have some typical atypical Parkinsonisms. So those are the ones that we call MSA or multiple system atrophy, progressive supranuclear palsy or PSP, corticobasal syndrome or CBS, and then more really atypical, so very rare to see and more difficult to diagnose. So when we are talking about vascular Parkinsonism, normal pressure hydrocephalus or NPH, other autoimmune disorders, genetic disorders like the spinocerebellar ataxias or Fragile X tremor ataxia syndrome. But today we're going to be focusing on the MSA, these atypical type of Parkinsonism. So I started talking about Parkinsonism, but what is Parkinsonism? Parkinsonism is just a description of symptoms that the patient is presenting with. The key characteristic of Parkinsonism is going to be what we call bradykinesia. Bradykinesia is the medical term for slowing down of movements. But many patients are going to present complaining of weakness. And sometimes when we test the patients, they have good strength, but it's this slowness of movement and how this slowness is affecting their daily activities that the patient perceives as a weakness. And then this slowness of movement has to be it has to be associated with either a stiffness in the muscles, that's what we call rigidity, or a resting tremor. That's the typical tremor of the hands when patients are distracted without doing anything. So with any of this combination, that's how we define the term Parkinsonism. Now let's focus a little bit more into multiple system atrophy, or MSA, which is one of these Parkinsonism. So first, we know that they have a prevalence of roughly about 0.5 per 100,000 in studies done in Spain. But in other areas of the world, like in Japan, we see as high as 17 in 100,000 people diagnosed with multiple system atrophy. There's some sex differences, slightly more in men than in women. And this is one of these diagnoses that there's not really contributing factors. Like we talk about Parkinson's disease, if you've been exposed to pesticides, there are some other genetic characteristics that will contribute for your risk of increasing to have Parkinson's disease. But with multiple system atrophy, we really have not identified any of these contributing factors. There's no environmental factors that we know or genetic disorders specific to multiple system atrophy. It is a disease that starts roughly in the mid-50s, and unfortunately, it is one of these rapid progressive Parkinsonisms that patients, in a short period of time, they can be very disabled in a wheelchair, and we know that unfortunately, some patients may end up passing away from the disease in a short period of time, between 6 to 10 years. Multiple system atrophy has had many different names, and sometimes you might hear this or seen on your medical records. So in the past, Shy-Driver syndrome, that's the what we consider the autonomic variant of multiple system atrophy. The olivopontocerebellar atrophy, when it was mainly ataxia or symptoms affecting the coordination of movement. And then striatonigral degeneration, when the main symptom or the predominant symptom was this Parkinsonism that we were talking about. But then in 1998, there was a consensus to try to simplify this, and all of this has been bunched into the multiple system atrophy, and this has been subdivided into two variants of multiple system atrophy: the cerebellar type, when the main symptoms are related to this discoordination of movement or problems within the cerebellum, or the Parkinsonian type, or when they have the Parkinsonism that I was mentioning before, but the main characteristic that is not responsive to levodopa, which we know Parkinson's disease usually has a very good response to levodopa. Some patients may have prodromal symptoms. These are symptoms that start very early before other more classical signs of the disease. The main one that we can see is this autonomic failure. So these symptoms of low blood pressure, changes in sexual function, changes in the function of our sweat glands, difficulty regulating your temperature. Those are the things that your nerves are controlling without your input. So there's nerves that are autonomic working without any control. So that usually starts years before other symptoms related to MSAs start. The other thing that we see very common is what we call REM behavioral disorder. So REM behavioral disorder is when you're in your REM sleep and you're dreaming, your muscles should get completely relaxed, so you're not moving, you're not acting out your dreams. But then during this behavioral disorder of REM, patients' muscles are not relaxed and they're acting out their dreams. They're talking, they're moving, they're punching, they're doing different tasks. And this can precede the other symptoms of MSA for many years. One thing that is interesting to point out is the lack of the sense of smell, or anosmia, is not common in multiple system atrophy compared to something like Parkinson's disease, that is very common to see the lack of smell in those patients. Now, what do we see in the brain? What is happening in the brain of patients with multiple system atrophy? You're going to hear about the alpha-synuclein. That's one of the main proteins that gets affected, but it's the same protein also gets affected in Parkinson's disease. But there's some differences of what happened with this protein. So this protein, as we can see, gets produce, and then it misfolds. So the proteins has to have a very specific structural characteristic to function well. But if they misfold, then they cannot function in the proper way. And then these misfold proteins of alpha-synuclein start to bundle together, slowly bundle until they form what we call this Lewy body, which is one of the hallmarks of this alpha-synuclein disease. So we can see this also with Parkinson's disease. But one of the characteristics is that in Parkinson's disease, usually we see this Lewy body buildup in the neurons in the brain, while in multiple system atrophy, it actually builds up in what we call the oligodendrocytes. So oligodendrocytes are kind of like the support cells inside the brain that are supporting those neurons. So this supporting cast gets affected by this buildup of alpha-synuclein. Now, we don't know if the alpha-synuclein is the actual toxic to these neurons that affect and cause them to die, or if there's something else that is causing them to die, and as a result, we see this alpha-synuclein to build up. Overall, the diagnosis of a multiple system atrophy is always going to be a clinical diagnosis. So what do we mean by that? That when we see a patient with multiple system atrophy, there's really not much testing that we're going to be doing. Most of the time is based on the symptoms, based on response to levodopa, based on the progression of the disease over time, is that we're going to make some decisions into, okay, are we dealing with, like you said, like you see on this table, are we dealing with a clinical established multiple system atrophy or a clinical probable multiple system atrophy? One of the key characteristics is going to be these autonomic dysfunction. So those nerves that are working without your input. Once those get affected, plus any of these Parkinson's symptoms or the cerebellar symptoms, we have those core features for established MSA. Then they need to have some at least two of the supportive motor symptoms. I'm going to show you those in a later slide. And then at least one of the MRI markers. And based on all of these characteristics, we're going to have established MSA. Of course, for all of these, there have to be absence of any of the exclusion criteria for multiple system atrophy. When we're talking about a probable MSA, is when they have at least two of the signs, but this may be somebody who has some cerebellar and Parkinson's, but no dysautonomia. So it's not quite as established, but it's a probable MSA. They have at least one of the supportive motor symptoms, and the MRI findings is not required for making this probable MSA diagnosis. So what are the supportive symptoms? I was mentioning there on the chart, you need at least two for the established, at least one for the probable MSA. So one, the rapid progression of the disease. So seeing this rapid change, at least in a course of 3 years. Moderate to severe postural instability. So what we mention when we talk about that is patients who have poor postural balance, that they can easily fall backwards, that they cannot control their balance when they're standing. Having cervical dystonia, this is when the muscles in the neck get affected and cause a torsion of the head. When they have problems with their speech, problems with their swallowing. When they have what we call a Babinski sign, this is a sign during the neurological examination that tells us that there's some dysfunction of the first neurons of the motor system. When they have very jerky type of reflexes or myoclonus. And then when we can see some contractures could be in the hands, in the legs, that cause an abnormal posture of the limb. Those are the motor symptoms that we can see associated with multiple system atrophy, that they're supportive of the diagnosis. Now, there's some other non-motor symptoms that can happen. Stridor, usually that happens when they're sleeping, when they breathing and have a noise like it's difficult passing the airway. An inspiratory sigh, cold discoloration in the hands and feet. So signs of this dysautonomia or the autonomic dysfunction, erectile dysfunction in patients who are under the age of 60, just because over the age of 60, there could be other factors that could influence that. And then we see with some patients a problem that is directly linked to some of the atrophy that happens in the brainstem, which is called a pseudobulbar affect, when patients can have this unusual laughter or unusual crying, and they can flip from one to the other in 1 minute or just during the same situation. So we mentioned that to make a established diagnosis of MSA, we need to find some MRI markers of multiple system atrophy. So some of these are changes that we look for on the MRI. They're not always there. So if we don't see them, does not exclude a diagnosis of multiple system atrophy. But if we see them, definitely it helps us to support our diagnosis. So we look at an area of the brain called the pons, which is in the brainstem, and we can see this sign that is called the hot cross band sign, because it looks like a hot cross band. We look at some signs of atrophy in the putamen. The putamen is this area around the brain that is closely related or part of what we call the basal ganglia of the brain, or these circuits in the brain that help control movement. So when we see atrophy over there, that's another suggestion that we could be dealing with multiple system atrophy. And then atrophy of the connection between the cerebellum and the brainstem. These are called the cerebellar peduncles. So these are fibers that are connecting your cerebellum with the rest of the brain and the rest of the brain. So when we see atrophy of that, is very suggestive of multiple system atrophy. And then just the atrophy of the cerebellum. You can see here a little bit more full cerebellum, but this is what it looks when it's more, there's more atrophy in that area. Similar over here, this is how normal bones should look like. You can see a little bit more flattening of that area of the brain, of the brainstem, suggesting that there is atrophy in the similar way, again, similar atrophy of the cerebellum compared to this picture will be normal control. So like I said, there are some exclusion criteria, and if patient has any of these, then it should really move us away from a diagnosis of multiple system atrophy. So if the patient respond well in a persistent way to levodopa, then it's unlikely that they have this atypical Parkinson. They're more likely to have Parkinson's disease proper. If they have the lack of the sense of a smell that has not been explained by other things. Of course, if you've had COVID or if you've had some other problems with your sinuses or nose, you may lose your sense of a smell. But if there's no explanation for the lack of a smell, then it starts making it less likely to be multiple system atrophy. Cognitive problems is rare to see multiple system atrophy, in the same way that dementia, hallucinations, those are less likely to be multiple system atrophy. If we see changes in the ocular movements during the neurological examination, it points away from multiple system atrophy and more to another atypical Parkinsonism called progressive supranuclear gaze palsy. Then if we see other signs on the MRI that are suggestive of some other problem, and of course, if there's some other alternative diagnosis that will explain better what is happening to the patient. Now, in the recent years, as we started using more skin biopsies, so not part of the diagnostic criteria right now by the Movement Disorder Society, but we're starting to use more and more of these as a way to try to differentiate patients who we have some question about the diagnosis. Now, the skin biopsy by itself doesn't really distinguish between these alpha-synuclein diseases. So the skin biopsy is looking for the deposition or buildup of these alpha-synuclein in the skin. And this can be measured when we're taking the samples from the neck and 2 samples from the leg, proximal and distal. And in this study, as you can see, patients who have Parkinson's disease, 92% had this abnormal biopsy. Multiple system atrophy, 98%. Dementia with Lewy body, 96%. Patient with what is called primary autonomic failure, 100% of the patient. And then the controls who had no Parkinsonian disorder, no neurological disorder, they only had in 3% of the patients were what's considered a positive biopsy. So it helped us with making a diagnosis of alpha-synuclein disease, but not quite to differentiate Parkinson's disease or multiple system atrophy or dementia Lewy body. But more recently, in a more specific analysis, like I said, we can look at where this alpha-synuclein is getting deposited, and there is some suggestion that when it's Parkinson's disease, we're going to see it along the projections of the nerve in the skin. So this is what we call the axon of the nerve, and that's where we're seeing this deposition of alpha-synuclein, compared to in multiple system atrophy that it might be more buildup of this alpha-synuclein within the body of the cell and not in the projections. So that may help in the future, not something that is right now established as part of the diagnostic criteria, but could help in the future to differentiate one from the other with these skin biopsies. So definitely more studies are going to be looking into that way to differentiate these symptoms, these syndromes. Because really, that's one of the key problems when we see patients, like I said, with these Parkinsonisms, that at the beginning, early in the disease, they can be very much similar and hard to differentiate. And for most patients, we're going to say this is Parkinson's disease. But then over the course of how they respond to the medication, what is the progression of their symptoms, we may change that diagnosis. So you may have been in that situation that your initial diagnosis could have been Parkinson's disease, and then later on at some point it was decided that it was probably more looking like the multiple system atrophy, and hence this change in diagnosis. So hopefully with this type of future techniques, we're going to have a better way to diagnose patients early in the disease, which also help us with selecting patients for future research. So this kind of want to thank you for listening. This is my introduction into multiple system atrophy. And these are some of the reference I use for this lecture. And like I said, some of the other speakers are going to be touching into the management and other characteristics of multiple system atrophy. And have some time also, I don't know if Alex, you want me to address some of the questions now or leave it for later?
Yeah, so I think we got a little bit of time for questions. I think it might be easiest for people to put their questions in the chat, but Donald Fay had mentioned a question, which we can't necessarily answer personal questions as this is an educational session, but does bring up a point about diagnostic testing. And Dr. Figari, if you wouldn't mind elaborating a little bit about when do you reach for these more advanced diagnostic testings and part of someone's workup with multiple systems atrophy?
Yeah, I think that's a good question.
And Dr. Figari, I'll jump in as well. Just to get, I think you really, gave a very good sort of rational way of assessing Parkinson's versus MSA. But I think when we think about the cerebellar type of MSA, sort of distinguishing that from, say, other causes of cerebellar ataxia, what are some of the tools that can be helpful, and what are some of the uncertainties that we may be left with?
Yeah, and I think a little bit touching to some of the question that is there on the chat. Again, at the beginning, when we see patients with these ataxia, primary ataxia or cerebellar symptoms, We want to rule out first the things that we know we can control it and we can that can modify to slow down the progression of disease, and that will include looking for metabolic disorders, autoimmune disorders, sometimes paraneoplastic disorders, or disorders related to some underlying malignancy. So once you exclude all of those symptoms, some patients may require genetic testing depending on what syndromes do they have. And then if all of these genetic tests come back negative, then they sometimes fall into this category of adult onset sporadic ataxia that don't have a diagnosis. And those patients end up being multiple system atrophy. And usually the recommendation is that you have to follow the patients for at least 10 years before you can say, okay, if after 10 years, the progression has not continued in the way that you would expect for us multiple system atrophy, then probably they do not have multiple system atrophy and they have some other, at that moment, unknown type or idiopathic type of cerebellar ataxia that for most patients is going to be that is a gene disorder that has not been discovered yet.
Thank you so much, Dr. Figari. And next on our panel is Dr. Kristina Caine, who's one of our movement disorder fellows in her second year, who's going to talk more about autonomic dysfunction in multiple systems atrophy.
Excellent. Thanks for the intro. Yep, so I'm going to focus on this dysautonomia, which Dr. Figari had touched on a few times. So we'll go into, actually, let's see how I move the slides here. There we go. Just kind of have a layout of what we're going to talk about today. So first, we're going to talk about what dysautonomia is, then, some common signs and symptoms of this, and then go into more detail about some of the more common symptoms that people experience that are due to dysautonomia, and then how we test for these things and the management and treatment of each of them. So what is dysautonomia? So this is a process where the autonomic system is disrupted in the body. But what is the autonomic system? So this is the autonomic nervous system. And as Dr. Figari alluded to, this controls a lot of the automatic sort of involuntary functions of your body, things that you don't think about that just happen, on its own. Managing your blood pressure, heart rate, your bowel, your bladder, and a whole host of other things like temperature regulation, sweating, sexual function, things like that. And as Dr. Figari also mentioned, this is very common in multiple system atrophy and is part of the diagnostic criteria. So what are some common signs and symptoms of dysautonomia? And a lot of you may have experienced some of these symptoms, more than one probably. Dizziness, feeling faint when you first stand up. This is due to your body not regulating the blood pressure and heart rate appropriately when you change position suddenly. And this can lead to this sort of dizziness, faint feeling. And sometimes people will actually pass out as well. And we'll talk more about neurogenic orthostatic hypotension in a little bit. Constipation and other kind of GI symptoms like bloating, nausea, those are also very common and very important to manage because, if you're too constipated, if your bowels and your stomach aren't moving appropriately, you're not going to absorb medications appropriately. And it's also just uncomfortable. And people will have a lot of urinary symptoms, kind of more urgency, having to rush to the bathroom suddenly. They can also have frequency where they're going more often, and even trouble emptying their bladder. So people will go to the bathroom and feel like they have to go, but they can't fully empty their bladder and have to go back multiple times to feel like they fully empty their bladder. And then also sexual dysfunction, erectile dysfunction. Dr. Figari mentioned that, especially in younger patients. And then leg swelling. And people can have also some kind of patchy discoloration in their legs, and sweating and temperature regulation problems. And everybody's a little bit different in terms of how this manifests. I would say that I definitely see definitely more of the dizziness, feeling faint, the constipation, urinary symptoms, and constipation, probably the most, essentially the whole list. Now, let's go into a little bit more detail about each one of the three that I wanted to highlight. So I've kind of mentioned this a little bit already, but neurogenic orthostatic hypotension. Orthostatic, ortho means kind of changing position, standing, and the hypotension is just low blood pressure, and this is related to a neurologic condition because there's other causes of orthostatic hypotension. So when you first stand up, your autonomic nervous system has to get the blood to your brain so that you don't pass out. Normally, this is related to blood pressure changes and heart rate changes. And usually, if you're hydrated and you're healthy, then when you're younger, you can get up and you don't get dizzy. But then, as we age, and also with conditions like multiple system atrophy, this system just doesn't work quite as efficiently. Your blood pressure and your heart rate have to be changed because gravity is now pulling at your body differently, and the body does this by narrowing the blood vessels in your body to help kind of push the blood up to your brain. And this, when this isn't functioning appropriately, the blood isn't getting to the brain, and you can get faint. And that's why we tell people to take their time when they first get up. And give it a minute before they can go from laying to sitting, give it a little bit, and then sitting to standing, and take your time. Neurogenic bladder. This is very much a very abbreviated kind of overview because there's a whole host of things that we can talk about with the bladder. But in general, your bladder communicates with your spinal cord and your brain. And with dysautonomia, this communication is abnormal. And it can lead to these symptoms that I mentioned earlier, that urgency, the frequency, and what we call retention, which is where you have trouble emptying your bladder. And these can be severe enough that it can lead to accidents, incontinence. And you can have more than one of these at the same time. And it's important to treat these because this can lead to infections and even kidney damage. So it's something that we really need to make sure that we don't ignore. Constipation and gastroparesis. So I'll define each one of those here in just a second. But with dysautonomia, the muscles that control your gut can slow down and just not function appropriately. And that can lead to constipation, which is where you have that trouble passing stool, you have less bowel movements, you're not going every day. And then gastroparesis is just where the stomach isn't emptying as fast as it used to. And both of these can lead to the symptoms that I mentioned earlier, this bloating, the nausea. And when you are nauseous and bloated, you don't really feel like eating. And then also the medication absorption issue. So you can imagine if you take, let's say you are taking the carbidopa, levodopa, you get maybe a little bit of benefit with it, or any of your other medications. If you take a dose and your stomach isn't moving the way it used to, it might just sit in a place where it's not getting absorbed, and then you go for your next dose, same thing, and then they all kind of move at the same time into the area where it gets absorbed, and then you're getting all this extra medicine, and then you've gone all this time without medicine. So it can really disrupt, the timing of medications and the absorption of it. And then also, if this isn't managed appropriately, it can be life-threatening, where people can have obstructions, meaning that there's a blockage in the bowel, and that can be a surgical emergency and a life-threatening emergency. So we want to avoid that as much as possible. Now, testing for dysautonomia, what we usually do is we get information from you, we talk to you, gathering a history and seeing if you're having any of these symptoms. And then also just doing an exam, seeing if, your exam is fitting with MSA or another neurologic condition that would have dysautonomia as part of the condition. And that's most of what we do. There is a lot of other testing that we can do that isn't always needed, and most of the time isn't, because we can get a lot of information from the history and the exam. One of the easiest tests that we can do in the clinic is just checking your blood pressure and your heart rate while you're here, but doing it when you're laying, sitting, and standing, and giving some time before we check the next blood pressure and heart rate, and then comparing those numbers and seeing if there's a dramatic change in them. That would suggest that you're having something like orthostatic hypotension. Here, we don't have an autonomic testing center. And again, a lot of times we don't need that. So it's really not necessary for the diagnosis of dysautonomia. There are some conditions where we do need to do more testing, but a lot of times we can figure it out through our exam and history. Each time I go forward, it skips multiple. There we go. All right, so management. So these slides can be a little overwhelming just because there's a lot of information here. And I really want to focus primarily on the non-medication options, because these are extremely important. These are things that you can implement right away, but they do require persistence, and they can be challenging to build into your routine. So for neurogenic orthostatic hypotension, as I mentioned, you want to really take your time when you're changing positions, especially in the morning when you're waking up and you're dehydrated. Sometimes I'll tell patients to have some water by the bedside, and that way they can drink something when they first get up and kind of wake up their body and give that a little time to go through your body before you start your day. Make sure that you're moving. You don't want to be sitting or standing for too long, and sometimes if you're in clinic for a long time and you're sitting and then we get you up to stand, it can trigger some of the dizziness. And you want to make sure that you're exercising, that you're moving, and not only sitting or standing or laying down all the time. Because the more you do that, the more your body gets accustomed to just being in that position. Makes it worse. Staying hydrated is very important. And also increasing your salt intake, because we really want to make sure that we're getting all the fluid into the blood vessels and not into your tissue. Like when you get swelling in your legs, you have fluid, but it's not in the right place. So we want to make sure that the salt can help kind of bring it where it needs to go. But know that there's some limitations with this, because some people have heart problems, and we have to be careful with how much fluid they're taking in or how much salt they're taking in. So just, this is on an individual basis, we talk about this, but it's usually very effective if people don't have any heart problems. Most of the time, people think that they're hydrated enough, but they're not. And the little extra salt can be very helpful too. And at home, if you're able to, also elevating the head of your bed can be helpful as well, just so that there's not as much of a dramatic change when changing positions. You can do this with pillows, or if you have one of those mattresses that can fold up a little bit, you can do that. And then compression stockings. There's multiple types of this. There are the knee highs and the thigh highs. And the thigh highs tend to be more effective, but they're not as well tolerated. And then also abdominal binders, which can be bulky, but the thought is with both of these is that we're pushing the fluid back up towards the heart and then to the brain. A lot of the pumping of the blood is just from the vessels, but also from the muscles, and moving helps move the fluid back to where it needs to go. And this is one way to compress it so that it pushes it back up to the heart and to the brain. With the abdominal binders and the compression stockings, you can find these in a pharmacy. One of our colleagues, Dr. Higginbotham, likes to recommend using Spanx for women because Spanx is just like an abdominal binder, kind of compresses and isn't quite as bulky. So that's something else that you could do. And then medications. Usually we try the non-medication options first and then continue them even if we start medications. And the more common ones are the midodrine and the fludrocortisone. And so you can see here that I have the generic and the brand names. And there's some issues with some of as everything does, there's side effects with everything. And one of the issues with some of these medications is that it can make your blood pressure really high when you lay flat. So the timing of the medication is important, and also just making sure that we don't overdo it with this. And there are also patients who have high blood pressure at the same time, so it can make it a little complicated when dosing these medications along with blood pressure medicine. And sometimes we have to even stop blood pressure medicine because people tend to start going, low blood pressure, start having more low blood pressure rather than high blood pressure. But know that this is something that can happen as a side effect of these medications, or some of these medications. There's some other ones that we'll do as well, droxidopa and pyristigmine. And sometimes we'll combine a few medications as well, but usually I try to keep things as simple as possible. Managing neurogenic bladder. So again, I'm going to focus on the non-medication options. So one thing you can do to help with the urgency, frequency, and retention is making sure that you're going to the bathroom regularly. You don't want to hold your urine. So make sure that you're having frequent bathroom breaks to help prevent incontinence. Also, there are certain juices like cranberry juice, or there are some supplements that can help with preventing urinary tract infections. Usually the supplements are also cranberry based. And then also, if you're going to have accidents and you can't avoid it, you can also use things like Depends and some other things like that. For medications, so the two favorites for me, and I think I can speak for everybody else too, is the vibegron and the mirabegron, the Gemtesa and the Myrbetriq. They seem to be well tolerated, and they seem to target the bladder a little bit better, but they can be expensive. And usually people are tried on the oxybutynin or the tamsulosin first. And most of the time these are prescribed by primary care doctors. But know that as everything does, they have side effects. The oxybutynin can cause, kind of dry eyes, dry mouth, can worsen constipation, can cause some confusion. And the tamsulosin can also lower blood pressure, which can be helpful sometimes, but not always, especially if you're experiencing a lot of the lows with the orthostatic hypotension. And then also, we do Botox, but we don't do Botox in the bladder. But some people get Botox or botulinum toxin that is injected to the bladder to help kind of relax the muscle. And then constipation. So one of the other things that's really important with constipation is to stay as well hydrated as you can. That'll help with the dizziness, that'll help with constipation. It'll also help, definitely make you more regular in terms of going to the bathroom to urinate. So that's the most important thing. One thing I'll note with hydration is that you want to make sure that you're staying hydrated during the day. And then in the evening after dinner, you want to make sure that you reduce your fluid intake so that you're not up going to the bathroom all the time. And that can impact your sleep. And if your sleep's impacted, that can lead to cognitive issues and also worsening of your overall, all of your symptoms. And so it's important to hydrate during the day. Physical activity can also help with getting your bowels moving. So there's multiple reasons why we recommend exercise. It can help with, the balance, kind of helping prevent you from having significant injuries if you were to fall, but also, helping with constipation. And then I put prunes here because prunes, like eating prunes, prune juice is kind of the first thing that people think of from a food perspective to help with constipation. And also there are some other foods, things that have high fiber can be helpful as long as you're hydrated. And then also kiwis can be very helpful too. In terms of medication options, there's a lot. And they all have their own sort of mechanism in terms of how they work. Again, usually we try the non-medication options first, but if you're not able to have regular bowel movements and need a medication, then you should do that because we really don't want constipation to get worse and lead to an obstruction or some other complication. And so you might recognize a lot of these, like Polase or Docusate, that's a stool softener. We have other ones that are like Senna or Senecot, Dulcolax, and these stimulate the intestines to move. And then osmotic laxatives like Miralax, lactulose, milk of magnesia, and these all sort of soften the stool, increase the water in the intestines to make it easier to pass. Fiber, as I mentioned, you can get fiber through your diet, but also something like Metamucil can help bulk up the stool and help as well. But again, you have to make sure that you're hydrated. If you're eating a lot of fiber and not drinking, that could actually make things worse. And then also, if needed, if all of these things don't work, you can also use suppositories and enemas. But I would recommend that you try these other options before moving in that direction. And that's it. That's all I have. It's kind of a general overview. One thing that I will say is that I've summarized this information on we all worked on it to create this sheet that's on the Mission MSA website. And so, this might be a good resource to have for reference. So when you're looking at medications and you want to see, well, how does this work? Or what are some other options I could try? And you can look there and get some ideas.
Awesome. Thank you so much, Dr. Caine. We are definitely a little bit ahead of schedule, so we have time for questions if people want to put them into the Q&A box. Dr. Shah has
Dr. Caine, thanks for that review. I think one of the biggest things that can be debilitating is the orthostatic hypotension component of autonomic dysfunction. And you kind of went through different options that can be used, medically and non-medication wise. Do you have from a medication standpoint, do you have a preference, or do you have kind of a hierarchy of medications you use and say, I usually start with this and really kind of keep ramping it up, add multiple agents, or is it just dependent on each individual person's presentation?
Yeah, I think and I didn't mention this, I really like to focus on the non-medication options first. The other thing too is also looking at patients' current medications and seeing if anything is contributing. So I definitely want to make sure that we're not making this worse by giving you a medicine that's making things worse. So reviewing the medications, doing the other non-medication treatments first. Because some of the Parkinson's medications that we use, also in MSA sometimes, can make this worse. And so if that's the case, then we can try reducing those medications. And then let's say if we have to use one of the medications that I listed on there, I tend to like Midodrine better. And I usually start a low dose, and then we want to make sure that we do it earlier in the day rather than later. So that's my favorite. And then I try to maximize that one if people are having benefit, but maybe not enough, and as we go up. And then if needed, we can add the fludrocortisone. But yes, I think that if I usually tell people to check their blood pressure and heart rate at different times of the day, and we want to make sure that people aren't having really high blood pressures when they're laying down on these medications. So if people are having really high blood pressure in the morning, that we don't want them to be having such high blood pressure all through the night, because that can increase your risk for stroke. And if people are having a lot of this high blood pressure at night, then we can use something like the pyridostigmine to help prevent that from happening. But usually my go-to is the midodrine.
Thank you, Dr. Caine.
Yeah, thank you very much. There's one more question that popped in the chat. It was a personal incident that Candace shared about treating some small bacterial overgrowth. Have you heard anything about that before, Dr. Caine?
I have. I guess I didn't mention this too, but sometimes probiotics and things like that can also be helpful. I think anything that's slowing down the gut, if we can try to prevent other things, like treating the kind of overgrowth. Yeah, sure. I don't usually look for that. That's usually diagnosed by somebody else, but it just kind of made me think about probiotics and how important those can be too.
Yeah, and I think it also speaks to the point that a lot of these symptoms may overlap with other conditions, and having an interdisciplinary discussion with your primary care and other people is usually worthwhile. But thank you so much, Dr. Caine. So next we have Dr. Dainton-Howard, who is one of our newest faculty here at UVA, who's going to talk about mood and mental health. And she's a dual certified movement disorder neurologist and psychiatrist. So very well equipped to share some insight on this topic.
Yeah, that's fine. Can you guys hear me okay?
We hear you loud and clear.
Oh, perfect. Very good. All right. Yeah. So thank you guys for letting me hop on and talk with you. So it's interesting because compared to some of our other conditions that we see in this group of disorders, we don't really highlight neuropsychiatric problems in MSA as much as we do in other conditions like Parkinson's or even PSP. So it was interesting to kind of look into some of this research, and I'm just going to tell you some more also about some of my experience using some of these medicines, some of the side effects you have to watch out for too. So it's going to be a little bit of a whirlwind tour through some of these things. All right, starting more with the psychiatric side of things. So again, this kind of talks about the diagnostic features of MSA, which has already been brought up. I just wanted to point this out here because even in the things that we've talked about before and all the other things that we see, we really don't mention a lot in the relation to mental health or other things that are going on. And the only thing that really comes up is the lack of cognitive problems that you have to have, because that can be an exclusion criteria for diagnosing this disorder. So, and that's one of the things that I just thought was really interesting. And patients do experience a lot of symptoms that come along with this domain, but there are studies that have shown that they're probably a little bit underestimated. So patients may be dealing with some of these things, and because again, like all of our disorders, MSA involves so many systems in the body, and we're coping with so many different problems that it may not, naturally come up when you're talking with your provider in clinic. But we did see it in a study in 2020 in a large MSA registry that patients are actually reporting some changes in mood, memory, and other issues that are going on. So you can see on here, acting out the dreams is obvious. We had talked about that. Some forgetfulness, depression, actually, kind of there in the middle of the group. The pseudobulbar affect, which was mentioned as well, which we'll talk about in a little bit. And then even actually some patients in more advanced disease with hallucinations, which is something we, for whatever reason, see a lot less in MSA than in Parkinson's, but apparently can still be present at different stages of the disease. And again, kind of like what we were saying, but they're less common. They may be missed, so don't be afraid to kind of bring them up to your provider if you're dealing with any of these things, because a lot of them are treatable. And so that's what I kind of want to drive home to you guys today. If there's nothing else that you take from that, you can talk with us about these problems. We can try and come up with different ways to solve them. And then just as a blanket statement, because pretty much every study or every symptom that I was researching was talking about, for whatever reason, these are all more common in women than in men. So rather than just reiterating that over and over again, it was just generally found that women are more likely to have these symptoms than men. The first thing that I'll talk about, because it's probably the most common that we deal with, and also one of the most bothersome symptoms, is depression. So just a reminder of what symptoms come along with this and how we diagnose it. It's not just feeling sad. It's more than that. So along with having a low mood or a loss of interest in your day-to-day activities, we should also see at least 3 or 4 of these other symptoms that are coming along with it. So changes in your sleep. Some people sleep too much. Some people sleep not enough. Again, not really enjoying things you used to enjoy. Feelings of guilt that are out of proportion to the situation that you're in, or feeling down and bad about yourself. Really low energy, poor focus, changes in appetite. Sometimes people eat a lot more. Sometimes they eat a lot less. Feeling like you're more fidgety, need to move around a lot, or that you're more slowed down, which is always, whenever you're dealing with Parkinsonism, is kind of hard to say because everybody kind of feels slowed down. And the last one, suicidal ideation or thoughts of self-harm. And so we can actually see this in our MSA patients as well. Studies have really varied widely, most likely depending on how they've measured depressive symptoms in their patients. But overall, about half of patients may be dealing with some of these symptoms going on. And some studies have shown up to even 80%. And it's probably the most consistent mental health issue that our MSA patients are dealing with. And it's actually been shown that these symptoms may be more bothersome for quality of life than the severity of disease or even loss of motor function because of how debilitating they can be. When patients are depressed and feeling really down, they may perceive their autonomic symptoms as being even more severe, so feeling even more of the effects of that lightheadedness on standing, or more bothered by your GI or urinary symptoms than you may be if your mood was under better control. And it's not 100% clear because we haven't done a lot of actual studies looking at the different types of MSA, but it's been suggested that this may be less bothersome in an MSA with cerebellar symptoms than an MSA with Parkinsonian symptoms, but that's not really conclusive. Like with a lot of other disorders, if we can get people's depression better, we can also get them functioning better, feeling better, and give them some better symptom management in general. And then kind of a cousin that comes along with depression and is frequently present in our patients is anxiety. And so when we talk about anxiety, that specifically refers to nervous feelings about threats that are not directly present. So fear, a normal response if a dog is running out of the street barking at you, you're afraid. That makes sense. But anxiety is more like going out in the world of being on high alert, worrying about things, always being on the lookout for those bad things. You can't really relax. So it's kind of that anticipatory fear that comes out. This can also include like general phobias, not wanting to go outside, not wanting to be exposed to certain things, or panic attacks where you can get really anxious, feel like you're losing control, heart's pounding, shortness of breath, all of those things. And initially, these symptoms may be more mild, but overall, as disease goes on or as symptoms evolve, anxiety can become more severe. And similar to depressive symptoms, it really depends on the study, like which questionnaires they're using, what patient population exactly they're looking at, how they're doing the measurements. So the prevalence is a huge range between 37 to 71, but definitely indicating that it's present and something that we need to make sure that we're taking care of for our patients. And there's also theories that we may see more anxiety with more severe orthostatic hypotension or in patients who are more severely disabled, which makes sense if you're more hindered in your ability to do things that you need to do on day-to-day life. All right, so there are a lot of things that we can do to treat these conditions. And along with that, because of MSA, there's certain things that we need to make sure we take into account to not cause more problems with medications as well. A lot of them are similar to what we do in your average community mental health clinic, taking care of general anxiety and depression. One of the easiest things to start with is talk therapy, like CBT or acceptance and commitment therapy, which can help us work through some of these feelings and give us better coping skills to manage those mood changes and that anxiety on a day-to-day basis. And there's also therapies that can help us adjust to big changes in our life, because I tell patients, they come in and say they're frustrated, they can't do what they wanted to do, they can't work anymore, they're not out hiking, they're not hiking around Europe, doing all this stuff. And then they wonder if it's normal that they're feeling upset and frustrated. And I think that's totally normal. And there are therapies that can help you work through some of those big life changes and kind of reframe your process of dealing with those day-to-day things. So that can be really, really helpful depending on what is going on and what the issues are. In general, we'll focus more on SSRIs and SNRIs. Sometimes use bupropion or Wellbutrin. These are all pretty well tolerated, SSRIs and SNRIs, especially for anxiety. Wellbutrin can be helpful for mood, especially with low energy. But we have to be careful with these medicines with some of the other MSA issues that we can have. SNRIs, especially venlafaxine, can make blood pressure higher. So we have to keep an eye out for changes in especially supine hypertension. I don't really use a lot of these medicines, but sometimes people come in with them from other providers for sleep or other things like that, or for pain. The things like amitriptyline or nortriptyline, the tricyclic antidepressants, can be helpful for those things, but they can also make constipation, urinary retention, cognitive fogginess worse. So we try and avoid those in patients who are already dealing with these symptoms. And mirtazapine is a good medicine for both sleep and for appetite, but it can also slightly aggravate that standing up lightheadedness. So we want to make sure that if we're starting that medicine, we're monitoring for any changes, or just letting you know, at least to let us know if anything else new or different comes up. And then kind of going back to what Dr. Figari had mentioned in his report, suitable bar affect or emotional incontinence is another thing that we can see in our patients. And this is defined as laughing or crying that is spontaneous and is out of context to the situation, or it's out of proportion to the given context. So I think that all of us have seen the really sad ASPCA commercials and maybe gotten a little bit tearful in those situations, but a person who is uncontrollably sobbing and can't stop in that situation may reflect a little bit more of this PBA that's going on. And or in a situation where there's no particular trigger, nothing that makes sense, they may be laughing excessively or may start crying without any clear reason. And the emotional response is difficult to control and not necessarily related to something the patient is feeling. So it's not necessarily that they're feeling really happy or really sad. The emotional response is just kind of coming out. And this is seen, again, in a variety of percentages, depending on the study and how it's done, but a fair number of our patients may be dealing with this, and it can be frustrating, embarrassing, and patients notice that it bothers them, if they're still trying to work, if they're trying to be social, to have these responses coming out that are kind of hard to explain. And so treatments, there's not a whole lot of stuff that we can do for these. The SSRIs and the SNRIs are good with some of the same effects that we have to watch out for. There's a medicine specifically for this called Nuedexta that we can use if it's really, really severe and really bothersome, but I've not had to use it. I've used it in more like multiple sclerosis patients, but not MSA patients at this point, because I've never seen it be that severe in an MSA patient. All right, fatigue. So this is another big issue that we see patients dealing with that is really hard to treat, but can be really debilitating. So about 25% of patients with MSA might be dealing with this fatigue, this general feeling of low energy, this feeling of exhaustion, but it can be as much as 66% of patients. It's important to note that this is not the same thing as being sleepy. When patients are sleepy, they're nodding off, it's hard to stay awake. When you're feeling fatigued, you're not necessarily having trouble staying awake, but it's just really worn down. Though it often accompanies daytime sleepiness, it may come along with use of medication to help sleep. Anxiety may be driving it as well, just kind of burning yourself out from being nervous all the time. But it's not really seen with more severe symptoms necessarily, more depression or changes in cognition in these patients. Over time, it can be more progressive, but it's not something that we can directly say, oh, as the motor symptoms progress, the fatigue is going to progress at the same rate. They're kind of separate entities. And it can limit day-to-day activities and can reduce quality of life, because if you're not feeling up to going out and doing things, you're going to not have as much social engagement, you're not going to be exercising, you're not going to be as active as you can be. So it's really important to keep an eye on this. And then, let's see. Like I said, there's unfortunately not a ton of stuff that's amazing for treating fatigue. So I wish I could say that I have a great pill, I can give you this and you'll feel a lot better, but we don't really have things that are awesome for that. Weirdly, trying to be active, even being gently active, can be helpful rather than kind of just sitting or laying and having trouble kind of getting up and moving around. That can help get things a little bit better. Having really low blood pressure can contribute to this as well. So there are some patients whose orthostatic hypotension is so severe that even when they're sitting up, their blood pressure is low. So they're really like loopy, low energy, feeling kind of awful, and you check their blood pressure and it's like 87 over some inappropriately small number. So keeping an eye on that and seeing if we need to do better to support those symptoms can be really helpful. Evaluating and treating for any underlying depression to see if we're actually dealing with more low energy in that setting is really important. And some medicines that can be tried are like modafinil, stronger drugs like methylphenidate. But, again, a lot of those you have to also be careful with blood pressure fluctuations. And a lot of them only kind of have so-so results. So trying to do some of these other things first, making sure we're treating any underlying problems, and behaviorally working on getting you a little bit more active and moving is probably the best way to start. We mentioned a little bit before about some sleep issues too, mainly breathing problems in sleep. And sleep problems actually may be even more of an issue in MSA patients than they are in our regular Parkinson's patients. Patients can have a lot of disruptions in their sleep, a lot of talking in sleep. REM behavior disorder is a very common problem, though interestingly, this can be more common, before diseases manifest, and may actually get better or taper off as disease continues to progress. But it is very, very common early on and up to 75% of patients. Other issues that are important to keep an eye out for are breathing issues and stridor in sleep, which can be a really big safety concern. So that, because you can have a lot of issues with your breathing overnight that we need to keep an eye on. And then anyone who's had trouble sleeping knows that it really makes your function bad on a day-to-day basis, even when you're otherwise feeling well. So poor sleep makes people excessively sleepy during the day. It can exacerbate a lot of other symptoms and just really wear people down. So we need to make sure that we're addressing these things to get people some good rest. So treatments, again, I'm really big on behavioral modifications. I'm always surprised at how many people I talk to who are still like, they'll wake up at 2 or 3 in the morning and then they'll get on their phone and they'll doom scroll. And it's like, we need to not doom scroll until 5 a.m. So the best way to kind of start is to make sure you're building the best sleeping habits for yourself possible. So go to bed at a regular time and wake up at a regular time. As much as you can, try not to nap during the day, as hard as that probably sounds. or if you nap, keep it short. Because if you nap a ton during the day and you're up all night, you're going to get your days and nights all mixed up. You'll be napping, sleeping. It'll just be a whole thing. So trying to consolidate as much of your sleep at night is the best thing to do. When you go to bed, make sure you're keeping the bedroom quiet and dark, cool if you like it that way. So no TVs, no radios, like a white noise machine is okay, but not a lot of like music, lights, put your phone away so you're not doing a lot of that before you go to sleep either. And then not doing other stuff in your bedroom. So you shouldn't be in there, like typing on your computer, working on your bed, doing all those other sorts of things. It's not going to be helpful for your sleep. Making sure that we're addressing things like sleep apnea or sleep-related breathing problems. Sometimes people do need CPAPs, and I know people hate CPAPs, but if they fit well and you get them working, they can be really revolutionary if you're having trouble with sleep apnea. So continuing to work with your sleep doctor to find a method that works for you is really important. For patients who are acting out dreams, melatonin is usually the first place to start. Or we can do very, very low doses of benzos like clonazepam, though if we have trouble falling overnight or being unsteady, we want to be really careful about doing that. Medications like trazodone can be helpful for sleep initiation, but we really try and avoid sleep medications like the Z drugs, Ambien, all those other ones in that family, strong benzos, Xanax. We try and stay away from all of that stuff because it can make people more unsteady, and you can become dependent on a lot of them for your sleep. It's not going to be good for your memory to be on those long term. So we try and avoid those things. And then another thing to kind of shift gears a little bit, something that you probably won't see as much at home, but if you wind up in the hospital, or if your loved one with MSA winds up in the hospital or gets sick, this is something that you may be dealing with, and it's good to know about. So delirium is a mental status change that comes along with an underlying medical condition. So it's relatively rapid changes in attention and thinking and behavior. A lot of confusion, patients may hallucinate, patients may lose track of where they're at, then they get very upset. And usually this is the result of something like a urinary tract infection. So, when they call us from the emergency room, the first thing that I'm telling them is, did you check if they have a UTI? They were fine 2 or 3 days ago, and now things are a lot worse. We got to rule that out. You can also see it with other things that can be bothersome. So lung infections like pneumonia, skin breakdown, bad bed sore infections. So big things that are going on there. Really bad constipation can flare this up. So those are all things that are important to rule out. If you're in the hospital for any reason, we try and get people in and out of the hospital quickly, because patients who have conditions like MSA really don't do well in those environments. Sleep can be really disturbed. People are up and down, things are beeping all night. Sleep, day and night get all mixed up. Lots of medication changes, possible procedures. It's just a hotbed of problems. So it's really common to see these symptoms in that setting. And we always want to make sure we're ruling out reversible causes when these things come up, especially since conditions like UTIs can be really common in MSA patients. A lot of them wind up in and out cathing with their urinary issues. Urinary retention can be, a trigger for developing more infections. Constipation can lead to some more of those issues too. So it's all important to keep an eye on. And when this happens, and when patients with this are in the hospital, we, again, find and treat the underlying cause. That's the main thing. Tell people to try and, again, regulate sleep-wake time. If people are really, really agitated, I really do not like using these medications if we don't have to. And in most Parkinson's patients, we'd say maybe quetiapine, because it has a lower risk of exacerbating motor symptoms. But the main thing to keep in mind with MSA is that if we use quetiapine as a medication for delirium, it can exacerbate lightheadedness on standing. So you have to be really careful. And then the inpatient providers have to be really careful to keep this in mind, because we already oftentimes have a lot of controlling the ups and downs of blood pressure in the hospital. So that's another thing that can just cause more issues. So unless someone was really, really bad straits, I probably would avoid using it. But if we do, we need to keep an eye on those blood pressure changes. So what about psychosis? So I'm really interested in psychosis in neurodegenerative conditions. Hallucinations, usually visual, seeing people and animals, occasionally some more delusions, paranoia, things like that come out. But interestingly, with MSA, we do see it sometimes. It's been reported. I've never seen it in the patients that I've seen. And it tends to be much less common than patients with idiopathic Parkinson's disease, and obviously less common in patients with dementia with Lewy bodies, since that's one of the cardinal features in that condition. So for whatever reason, fortunately, we don't see as much of this in MSA. So, all right, so moving on a little bit, I thought it was warranted to talk about some of the cognitive changes and changes in cognitive profile that we can see as well. Again, this is not something that is as common in our patients with MSA, and it's certainly not something that we expect patients to be presenting with. So you shouldn't have someone with dementia coming in and then getting an MSI diagnosis, or a lot of fluctuations necessarily getting an MSA diagnosis, because that may be more concerning for another condition like dementia with Lewy bodies. But there are some cognitive changes that we can see over time, and it's good to know what to look for. So again, memory changes after all. More recent research suggests that maybe 14 to 16% of MSA patients may be dealing with some of these symptoms. And we have to know to look out for them and recognize them, because they can affect patient quality of life, and caregiver burden can be increased. And it's one of the many things that can lead to an escalation of care, maybe placement in like a living situation, a nursing home, something like that. So what kind of things do we see? And not everyone with difficulties in their memory or thinking has dementia. So we want to know that they could be some minor changes that don't meet full dementia criteria. Excuse me. These tend to be unsurprisingly similar to some of the things that we see in our Parkinson's patients. So specifically, executive dysfunction. So, changing from one task to another, modulating your attention, making decisions, controlling impulses, all of those things can be things that come up. Patients may be kind of inflexible, so when they get fixated on something, that's what it is, and it's hard to get them off of that. They can be apathetic, which is low motivation. It's very different from depression, because in depression, people feel bad. When people are apathetic, they are just like, meh. They're kind of happy to sit at home. Someone's like, let's go do the thing. And they're like, I'm not really motivated to go do the thing. So it's a little bit different, and it's more kind of coming along with these issues. And changes with attention can be seen as well. We actually can see some impulse control disorder. So trouble kind of curbing behaviors. And one of the ways that we can see this are patients get started with something and they can't stop. So that's why we talk about and monitor for issues with things like gambling, because you start gambling on your phone app and you just keep going and going and going, and before you know it, you spent a ton of money. So you got to be careful about that. You might go out to, buy a shirt, and then all of a sudden you just keep taking more shirts. You come home with a pile of shirts. That doesn't make any sense. Or you're like, I'm just going to eat a little bit of this Ben and Jerry's, and before you know it, the whole pint is gone. So that's the kind of thing that we tend to see there. And actually, they did find that these changes in cognition in general may be related to progression with some of the autonomic symptoms like orthostatic hypotension, and probably mild cognitive impairment, where you're seeing some definite changes that would be considered abnormal, but you're not having trouble with your day-to-day function because of the memory. Is probably more likely to be seen than a full dementia diagnosis, where patients are actually having changes in their day-to-day function, needing more assistance, not being able to do their ADLs because of their thinking, not because of their motor symptoms or their autonomic symptoms. And so there are treatments for this. Again, it's less common, but we may have to manage these things. So we also, again, want to make sure we're treating the whole gamut of underlying problems that can contribute to these issues. Mood changes, blood pressure fluctuations, pain or discomfort, and poor sleep are all things we want to make sure that we have locked down while we're evaluating this. Encouraging people to be physically and cognitively active, socially active can be really helpful. Cognitive therapy, which is done by speech therapists, is really, really good to work on different strategies with patients to make these domains stronger and make their function better. And sometimes with all of this going on, if we are seeing a trend more into changes in function, which again is less common but not impossible, acetylcholinesterase inhibitors like donepezil and rivastigmine would be first-line choices here. All right, and so that was kind of a whirlwind review of everything. I'm happy to answer any questions. It looks like there's something. Oh no, there's not. That's the old one in the Q&A. If there's anything you guys want to know about, yeah, hit me up.
Yeah, thank you so much, Dr. Howard. One question I had was when we start thinking about the SSRIs in terms of anxiety, some of my patients, start to ask which one is the best because there are so many different options. Is there one that you gravitate towards for individuals with MSA?
Not particularly with MSA, but there are ones that I kind of gravitate towards more in general for certain reasons, especially in this patient population. So I usually avoid paroxetine because it has a very short half-life. It only lasts 18 hours. And if you miss a dose, you can have bad withdrawal side effects. Kind of like if you stop Effexor or something like that sudden, you just feel really awful. And it also is the most anticholinergic out of all of the SSRIs. And the last thing we need in any of our patients in our clinic is to have anticholinergic stuff on board. So I generally don't use that. And I don't use Prozac or fluoxetine as much because it can be a little bit activating and people find that one tends to make them a little bit jittery. So targeting anxiety, it's not a bad medicine for it, but you might see a little bit more of that. The medicines that I tend to use the most are probably sertraline. You can start at lower doses and kind of taper up around 100 to 150 is where you'll probably get the best benefit, but sometimes people feel better at lower doses, and that's totally fine. That one can kind of make people feel a little bit numbed down though, so some people don't like that as much, but it can be really good for anxiety, and it's usually, aside from that kind of blah feeling, pretty well tolerated. And then Lexapro or escitalopram is the other one that I really like. And that one, you can start at 5 milligrams and go up to 10. You do have to watch the QTC a little bit more carefully, especially if you're going to go above 10 in some of our older patients or in people with heart problems. But that medicine, it tends to work really well. It just works on serotonin, so it's a pretty clean medicine, and that's nice. The other ones I just generally don't use citalopram because there's escitalopram and fluvoxamine because it's really used more for OCD.
Right.
And then the SNRIs are actually really, really good for anxiety. And venlafaxine for Parkinson's patients has really good evidence for both mood and anxiety. So that would be a good one to go for. The only thing you do have to watch out for is it can increase blood pressure, which is probably good during the day. But at night, if people are laying flat or laying down, you want to make sure that it's not getting too high. Kind of similarly with duloxetine, but you also have to watch people's livers with that. That one usually is pretty good too. So I would say probably in general, my top ones would be sertraline, Lexapro, and duloxetine. I know that was a lot of talking, but does that help?
Yeah, that's awesome. No, that's a great description. Very helpful. We did have one question. You mentioned you did not use Nuedexta very frequently. Was that because you had a preference for another agent, or just the number of people who have suitable affects? You just don't.
I just haven't seen that much of it in MSA, so I haven't tried it in MSA. I've used it before in patients who have like demyelinating conditions, and it works really well. I wouldn't be averse to using it. I just haven't tried it myself. And the nice thing about the SSRIs and the SNRIs is you could hit a couple of different things with one medicine. So if you're having people who are also having some mood issues or anxiety issues, it's nice to just do one pill to tackle multiple things. The Nuedexta only does the pseudobulbar affect. So it kind of depends on the situation. I'd have to kind of revisit that. If a patient came in and had a lot of issues, then I might consider it. So yeah, so Ativan for severe anxiety. I think that the problem that I get concerned about is not so much the dependence, but the changes that we can see with walking and thinking. So especially with patients, if you're having more of like a cerebellar MSA, I don't want to make you more unsteady. Or if you have bad walking with your Parkinson's, I don't want to make you more unsteady. So those are really more of the things that concern me. And then I also think it's the way that you're using the benzo matters too. So if you have like Ativan that you take, once in a while, for severe anxiety, that's one thing. But if you're taking it on a scheduled basis multiple times a day, then you might just be perpetuating some of that underlying anxiety. Not so much with Ativan, but some of the shorter acting ones, you can get rebound anxiety. And that's what really more of an issue even than drug dependence is. It becomes something where you're trying to chase those symptoms. So, I think that it's really more of those other reasons why I try to avoid it in patients. And I say as they get a little bit older, and it's just not going to be the safest medicine for most people in the long term as far as thinking and walking stability goes.
All right. Thank you, Dr. Howard. Appreciate
Awesome.
it very
Thank you, guys.
much.
I really appreciate you letting me talk.
Yeah, absolutely. So if we look here. So I'm Alex Caine. I'm, like I said before, I'm one of the movement disorder nurse practitioners here, and I help run our multidisciplinary clinic. And I today will share more about our clinic and how we treat our patients here with multiple systems atrophy, and thought it would be interesting if I could walk you through one of our clinic days with our different therapists and allied health professionals to see what it would be like if you actually moved through our clinic with real recommendations. So I have done a couple of ad boards, but none of them are pertinent to this talk. But the main objectives today is to understand the gap in the current model for multiple systems atrophy. So where are the pitfalls and how do we try and solve that with our clinic? And then how do we use the multidisciplinary clinic to help with this chronic disease management of someone with multiple systems atrophy? So first, we'll talk about how we currently care for folks with MSA in the general population and some certain limitations. And then how does our clinic help support those limitations, talk about our personnel, our stakeholders, and the structure in which we undergo and use the clinic. So Dr. Figari talked a little bit about how common multiple systems atrophy is, which if we compare it to something like Parkinson's disease, it's not as common, which does prove to be a little bit challenging in the diagnosis. So there can be a bit of a delay when we make the diagnosis of multiple systems atrophy. And the diagnostic accuracy, ranges in that 60 to 80 percentile. And usually this diagnosis requires some subspecialty evaluation, which sometimes is challenging to access. And this is all can become problematic as we delay the diagnosis, we delay the initiation of these supportive therapies. So trying to have a care model that allows for this rapid diagnosis and then mobilization of resources. So MSA care is overall quite fragmented, and this applies for Parkinson's disease and other conditions as well. So people will access kind of the health system here through their primary care provider, general neurologist, their physical therapist, OT, speech therapist, neuropsychologist, or so forth. So trying to get to that endpoint of a kind of a movement disorder clinic can be a longer path. And during that time, if the diagnosis isn't made correctly, there can be more ambiguity, there can be delay in treatment. So that can be challenging. And then even at a major academic center that doesn't have kind of good systems in place, even coordinating care between people within a system can be challenging. So trying to talk to your primary care provider, your physical therapist, even if they're in their same town, that communication is just simply challenging. And this fragmentation will lead to this difficulty of developing these cohesive and comprehensive care plans. And this is important because the burden of multiple systems atrophy is not insignificant. So the diagnosis alone can be quite a symptom of itself, whether it's the fear of what is to come or the kind of journey that people need to go on to reach this diagnosis. And during that time, a lot of patients end up teaching themselves about multiple systems atrophy. And luckily now through sites like Mission MSA, the quality of education out there is so much better. But historically, and even now, sometimes people reach for these lower quality information sources, whether it be through unregulated social media, online antecedents, and well-meaning, but sometimes inaccurate advice from acquaintances. And ideally, this education should come from people who have understanding of multiple systems atrophy. But the symptoms of multiple system atrophy are also quite diverse. So it's a syndrome that affects multiple different body systems, like we've talked about through our previous panelists. They range from the motor symptoms, the balance, the cognition, the swallowing, blood pressure, the different autonomic symptoms, the ambiguity of what is to come, and speech changes. So it's a syndrome that affects multiple body systems, and you can't just focus on one symptom. So what that means is that it's advantageous to have these models of care where you can have this one-stop shop to have people evaluate all of the different challenges that an individual faces, which can just be challenging to be done in a 20 to 30 minute follow-up visit with your primary care or even with your neurologist. So many patients do benefit from this more comprehensive model, which is what we're going to talk about. So the main question is why even bother pursuing this comprehensive approach? And that's because MSA is this complex diagnosis with many different symptoms that can pop up. And we believe that teams, not just the individuals, are going to be able to deliver these tailored plans for patients and families with multiple systems atrophy. And that's what motivated us to build this comprehensive care clinic to provide this more comprehensive care coverage. So I want to introduce you to our team. People get this reference, but our team, who really, I think, are the backbone of our clinic, ranges from our movement disorder neurologists, like the people you've seen talk today, myself, physical therapy, occupational therapy, speech pathology, our neuropsychologists, dietitians, and social workers. And all these team members are present on the same day, so it allows for real-time collaboration and care planning. And we chose these disciplines intentionally because they represent the specialists or the allied health professions that MSA patients are most likely to interact with the most often. And like we said, this allows for this true one-stop shop for the evaluation, the education, and then coming up with these different solutions. In the future, we'd love to have other specialties like palliative care, gastroenterology, geriatric medicine, and primary care, but that is all a work in progress. I didn't realize these are all coming next to each other. Okay. That's good. So the patients are the other part of this equation. And a key component is making sure we get the right people in at the right time so we can get them the help that they need. So we serve a large portion of the people that come into this clinic have multiple systems atrophy, but we also serve other different conditions as well, like other atypical processes like Dr. Figari had discussed, including progressive supranuclear palsy, cortical basal degeneration, and some of the spinal cerebellar ataxias. And this allows us to have this comprehensive model for these more complex conditions, but we're focusing on multiple systems atrophy today. So I want to introduce you to our team here at UVA. And my plan is to walk you through a typical clinic day that a patient would experience as they move through our clinic with real recommendations from our specialists. And I'll introduce these individuals as we move through the clinic. So typically, this visit starts with either our nurses, Joy or Tyler, completing a pre-visit phone call, using a structured interview process with the main goal to identify key issues and priorities so the team is prepared before the patient even arrives, which this allows us to mobilize resources and begin discussing solutions even before people come into the clinic. And as people move through the clinic, each of the specialists will gather information, offer recommendations, and then hands off to the next provider in line, which during that handoff is when that collaboration happens. And as that builds on itself throughout the day, we start to build into this more comprehensive plan. And then at the end of the visit, the plan's reviewed with the movement disorder provider with final recommendations and to wrap up care. Now, you can imagine that seeing this many people takes some time, which we are intentional about and try to keep the clinics under 3 hours, which is sometimes not always possible, but we do our best. And we typically want everyone to see everyone, even if it's just briefly. But the reality is sometimes people just have higher priority problems, like if speech is a bigger issue, they'll spend more time with the speech therapist comparatively, but feel passionate that everyone should get some face time with all of our different individuals. So the movement disorder neurologist or advanced practice provider or nurse practitioner, which is me, I intentionally kept this slide simple because I don't think we're really the highlight of this team. All of the different therapists and other professions, I think, are the highlight. But overall, our main role is to be an anchor point through the visit, which we will help coordinate and support collaboration across these specialties, and also serve as that role of providing the diagnostic guidance and clarification, and then helping manage the different symptoms that pop up from a medication perspective, like Dr. Howard and Dr. Caine discuss. So whether that's treating like low blood pressure with midodrine or fludrocortisone, we can address all of that when we see patients in this clinic. And then another major responsibility is, as you see all these different providers, a lot of the need for that coordination and referral and documentation pop up, which we provide all at the same time. So as people leave, they have all the prescriptions, referrals, they know where they're going, and that's all done at the time of the visit. So we really try and help to activate and connect all the resources that are identified that are needed throughout this clinic. So our first specialist is Lauren Berman, who is our occupational therapist. And she focuses on helping people maintain or improve their ability to participate in daily tasks and meaningful activities. So in other words, given someone's symptoms or limitations, her job is to how do we translate that into some functional success? So whether that's like buttoning a shirt or washing dishes or completing kind of any activity someone wants to do, she helps to bridge that gap. So one common thing that she talks about in her clinic during this is helping people get dressed with multiple systems of atrophy, whether it be the incoordination from a cerebellar standpoint or from more of the Parkinson's slowness and lack of dexterity. And she provides a lot of recommendations on adaptive clothing, especially items with kind of these magnetic buttons. And she has some brands that she recommends, like Magna Ready, and then starting to see more from larger clothing brands that now offer adaptive clothing. And she can go through with people and pick out ones that work best for them and then help make those recommendations at that point. And want to be clear that we have no connection with any of these brands at all. This is just what Lauren has felt confident with over time. The next person is our neuropsychologist, Dr. Caroline Hinkle, who's been with us for about 2 years now. And her primary role is to help evaluate cognitive symptoms and provide diagnostic insight from that perspective. So like Dr. Howard was talking, sometimes that cognition can be hard to evaluate. So she is our expert to help tell and tease out what kind of cognitive syndromes are developing. And then also focuses heavily on emotional well-being. So many times she spends most of the time talking about some key areas. One is medical legal planning, such as identifying power of attorneys, completing advance directives, and discussing long-term care preferences. And she guides these conversations with families, which is incredibly helpful. And then spends also much of her time talking about different cognitive strategies And a lot of these are more behavioral, so she can come up with solutions like doing one task at a time, using checklists and reminders, building predictable routines, and she can help walk people through their day and develop these real-life strategies to help navigate some cognitive limitations. And she also starts to talk more about anxiety and stress, which sometimes frequently accompanies these cognitive symptoms. And she can teach these deep breathing techniques and also help people get set up with these apps on their phone like Calm or Headspace, which can help with this kind of more at-home behavioral therapy. And she just does an absolute phenomenal job helping the patients and our families navigate the cognitive and emotional aspects of multiple systems atrophy. Next is our physical therapist, Dr. Diane Huss. She has been with our clinic for quite some time now. And her key role is really evaluating the gait and the mobility of our folks with MSA. But very importantly as well, she goes beyond that and starts to look more at the home environment to identify barriers and safety concerns. And she spends a lot of time investigating falls, digging into why they happen, and then can develop more creative strategies to prevent these falls. So some of the things that she commonly talks about with our patients is developing these targeted balance exercises, really depending on people's exams that she does with them. So sometimes she'll notice there's a lot of tightness in the calves or the hamstrings that throw people off balance, and she can develop these pretty targeted therapy recommendations that people can do at home. And she also helps people to identify different fall alert systems, whether it's using these step tracking devices or using different bracelets or like these fall emergency bracelets, and then can also help set up more with the different exercises for people to help prevent falls. And she does spend a considerable amount of time evaluating people's environment. She can't go into the home with people, but as people talk about their home, where they fall in the home in different problem spots, she can help develop solutions to mitigate risk. And one common area that she talks with patients is the nighttime bathroom trips when imbalance and low lighting increase the falls. And some common recommendations she is having good nighttime lighting, using bedside urinals or commodes just to limit the amount of mobility needed at night. And then she has good referral networks of different pelvic floor physical therapists, which can be helpful as well. Our next member is Renee Bricker, who is our speech therapist, and she has quite a large role. So she evaluates our patients for swallowing and speech concerns. And very importantly, which is sometimes overlooked, is looking at the communication challenges people can develop, whether it's from the ataxia or from the Parkinson's side. And as I put this slide together for her, she didn't have any universal recommendations, as she finds that most of her strategies are rather tailored. But commonly, as she works with patients, she begins to identify the specific type of speech difficulty and then can develop more personalized strategies. So if the voice is more slurred, if it's more soft, if it's more garbled, if it's more ataxic, she has these different strategies depending on what the different deficit is. And some of the common recommendations she gives are using these breathing devices to help strengthen the muscles used in speech, and then using very simple strategies like reading out loud every day to help train the voice. And another is that she can start to explore more about the personal barriers to communication. So is it motor? Is it more relational? Does it happen more in public when ordering food? And digs deep into what is the situation where this becomes more problematic. And then she can develop these strategies to help mitigate those. Another primary role with Renee is that she does all of our swallowing evaluations and can do standard evaluations in the clinic to screen for risks of swallowing. And then if needed, she can work with our ENT or colleagues about doing more advanced swallow studies and then give more tailored advice based on that. And one thing that she's passionate about is that essentially all of us should have good oral care, because this can reduce the risk of aspiration pneumonia in individuals with dysphagia, or dysphagia is trouble swallowing. And then Eleanor Hayden, she is our registered dietitian, and her role is about evaluating people's different preferences and goals and daily routines from a diet perspective, with the main goal to help support good health with a good diet. And goes beyond just the kind of granular food selections and calorie requirements. So she talks a lot about unintentional weight loss in multiple systems atrophy, and common themes that she starts to recommend people are not to skip meals, add lots of smaller snacks throughout the day, and then using reminders every few hours to eat. And typically recommends to eat when the energy is the highest, where people are less fatigued, which can help stimulate the appetite and make eating easier. And then with more specific food strategies, she is a proponent of high calorie options, which can either be more ready to eat foods, which just make it more convenient and sometimes more calorie dense, and then supplementing with more high calorie beverages like protein shakes and all these different supplements that we can add. And a nice thing is that she can help find these solutions, as some of these supplements are not the most palatable to consume. So she has tricks to get around that and make it taste a little bit better. But really, she's the one that provides a lot of support in diet and helping prevent weight loss, and then answering questions about different diets if people want to follow them. And then Laura is our social worker, who is really our expert at navigating the healthcare and insurance system all the way across the US. So she spends a lot of time helping people apply for Medicaid or Medicare, activating long-term care insurance, and starting to identify community resources and support services for our patients. So two of the big categories that she spends a lot of time talking with our patients about is gathering the support needed for care. So over time, as multiple systems atrophy progresses and the care needs change, she helps to talk about people's preferences and what resources are local in terms of long-term care options, different community programs if people's local geographic area has them, and very importantly, different caregiver support resources, because they are a huge part of the equation of what makes someone successful. And she works very closely with Dr. Hinkle, the neuropsychologist, about advanced directives, power of eternities, and really talking about the preferences of what does the future of care look like. And she also talks a lot about preparing for change. And that goes beyond just picking out different support systems or caregivers to come into the home, but can talk about some of the financial aspects of it. How do you pay for it? What are the best ways to go about that? Finding those local resources. And then as they come up with plan A or the preferred plan, she is a big advocate for creating a plan B or a backup plan, which she will do with people. So if the plan A does not pan out, what is kind of the next step to do? And she can also help start to navigate the conversation about pursuing things like assisted living. So there's so many different kinds of assisted living out there in different tiers, and Laura is an expert at knowing our local resources here in Charlottesville and in Virginia, and can help people figure out which location works well, which level of care, and then starting to identify which one works best with someone's insurance, whether it be Medicare, Medicaid, private, or self-pay. And she can help guide those discussions and then follow people along over time too, to make sure that they're successful. And our next people, so Joy Lanphier and Tyler Hughes are our two nurse care coordinators, and their main role is to keep this clinic, or essentially keep this train on the rails. So they do all of our pre-visit support, which makes the clinic more efficient and really maximizes people's time during the clinic session. And then they provide a lot of the end of visit education after we all leave the room, answering final questions, putting together these packets so people have all the information in one place ready to go. And then critically, they are the primary point of contact between visits to help answer questions and concerns and relay information between the different specialists. So essentially, we could not run this clinic without them. And I really think they're the backbone that supports every patient interaction that we have during our clinic. And the benefits of this care model, we think, and we've seen in other different models, like in Parkinson's, is that typically this facilitates the right intervention at the right time. So getting people the care that they need in a more comprehensive fashion. And we can see this reduce emergency room visits by proactively addressing issues that pop up, and a lot with risk mitigation, like preventing falls. And it provides better education as you have a diverse team with diverse viewpoints, helping to find solutions to these different problems. And a lot of times people, as they leave, they feel better as they're more supported by the team and more confident with navigating disease. And from a staff perspective, most people, if not all people, genuinely enjoy working in this multidisciplinary clinic, and is professionally fulfilling. And we've seen better retention at UVA as people work in these clinics with us. And that is all I have. So this was kind of an introduction to our clinic and an attempt to walk you through what someone with MSA would experience in our multidisciplinary clinic. And I've seen a couple of questions pop up.
So thanks, Alex. I think what we'll do is we're certainly running ahead of schedule. So I think there are a couple of questions that I think would apply to your talk, and I'll present those to you. But some of the questions, I think Terry asked about Ibogaine. Our next talk that I'll give is about sort of therapeutics and MSA, and we can sort of address kind of agents that may have benefit or anecdotal benefit, and sort of how to approach those types of things with the Q&A after the next talk. For you, Alex, there are a couple of questions from Michelle about sort of a multidisciplinary model in terms of having specialists and sort of where the role. So we have sort of neurologist and neurologic APP. We all have specialized training and experience at things like autonomic dysfunction in sleep medicine. But there are sleep specialists that's all they do. Can you speak to sort of why, what the challenges, what the limitations, what maybe some of the efficiencies or inefficiencies are of having sort of people like sleep specialists in the multidisciplinary MSA clinic, or urologist or things like that?
Right. No, and that's a great question. And I think overall, we'd say that it would be amazing to have everyone in one room see all of these different specialists, whether it be sleep medicine or urology. But the unfortunate reality that we sometimes face is that one is we have to be realistic with how much time can we spend. So as we add more and more people, there are limitations in, does it become a 4 to 6 to an 8-hour visit? So there has to be a little bit of delegation in what specialists we pick, but also about having and finding people to come into clinic to see our patients is also challenging. So kind of when we start to think about these sleep specialists who specialize in MSA are quite rare and far between. So finding people like that, even in our system, can be hard. But we are always on the lookout, and some of our primary people that we are shooting to add to our clinic are urology and geriatrics. Probably geriatrics being a little bit more accomplishable than some of these other subspecialists. But a big barrier is about finding the right people who have the time to come into these clinics. But obviously, we would love to have, all of them.
And I think that's an important point, Alex, which is it's sort of what can we provide and what can we not provide. So as sort of specialized neurologists, just sort of reiterating, we don't send patients to sleep specialists very often because we manage sleep issues and we have experience and expertise doing that. Similar to autonomic dysfunction, when we think about things that we can't do, many of them can be procedure-based. So I mentioned urologist, bladder Botox, was mentioned, I think, by Dr. Caine, where that requires specialized, settings and specialized training. But then there's an inefficiency of sort of, you can't get a urologist to spend an entire day in clinic out of the operating room. And so I think that's where we have to work closely with our colleagues in other specialties. Michelle also had a question about wheelchair therapy that I think you mentioned.
So at UVA, so Diane and Lauren, so Lauren is our occupational therapist, Diane is our physical therapist. We have a wheelchair clinic at UVA. So as the need arises for this help with mobility, we have a process. It's a clinic that's outside of our own, but they can help start to develop these recommendations as we get these individuals into this wheelchair clinic. And the advantage is that they can find the right make and model and fit and size, and they can add the extra padding they need. And then we can evaluate that in clinic, and they can have this collaborative crosstalk between our MSA, PTOT, talking with our kind of wheelchair durable medical equipment personnel. So we can get this a little bit more customized approach as we start to look at these assistive devices.
Great. And then I think Snap asked a question about distinguishing MSA from primary autonomic failure. And what I might do is maybe after the last talk, we'll have sort of, we have time devoted to Q&A for all the speakers. I think that question perhaps is best for Dr. Figari, who gave the first presentation. So I want to make sure that, we sort of have time to answer that question and similar questions sort of in the sort of panel discussion at the end. So Snap, make sure that we get back to your question. And Terry, I will not ignore your question about ibogaine and similar things in the next talk.
All right. But I think we're ready to roll into your talk, Dr. Shah.
All right. Thank you, Alex. And I just want to thank all of the speakers. I apologize for not being able to chime in during the introduction. Unfortunately, a patient issue came up with somebody who needs some resources, and it's entered the legal system. So it's always a challenge dealing with complex and chronic medical and neurologic conditions. And so multiple system atrophy really characterizes that. And my talk is focused more on kind of medical therapies that we apply now, but really I wanted to focus more on research updates and what the promise is, what the limitations are, and kind of how we sort of adjudicate different agents or new things that may show promise in sort of the clinical trial framework that we have in sort of our healthcare system in the US and for much of the world. So I have some disclosures. I've been on an advisory board the last couple of years for Abbott and AbbVie, not related to multiple system atrophy. And then some learning objectives. So, a little bit of a review from what Dr. Figari mentioned, our current understanding of what the pathologic basis of MSA is. And that really is important to help understand what the sort of therapeutic approach is for many of the experimental treatments that are being investigated currently. Discuss current pipeline therapies in MSA. And by pipeline, I mean along the spectrum of what we think of as phase 1 through phase 4 treatments. And I'll review that, what the pipeline is, as well as agents within it. Clinical trial resources in MSA. And the outline for the talk is, we'll talk a little bit about epidemiology, again, kind of to review what Dr. Figari mentioned. What are current treatment paradigms we use? What are clinical trial phases? And then some about the pathophysiology of MSA, experimental therapies, and how to learn more about trials and participate. Because one thing that's clear about that to all of us that see and provide care for people with MSA is, this population of people, those of you on the call outside, are some of the kindest people that we meet. And a lot of times it's not so much what can you do for me, but what can I do to help the next person, and learning about trials, participating where it's feasible, but really providing, knowledge for the future is something that I think we all find important. So these are pretty much the identical numbers that Dr. Figari gave. There's no sex predominance in MSA. The sixth decade of life is the typical thing. And MSA is one of those disorders that are neurodegenerative where there are a few others, but less common, where people can age out of likelihood of considering MSA. So unlike things like Alzheimer's and Parkinson's, where the older we get, the more likely we are to develop those things at a certain point, MSA becomes less likely as we move into the eighth decade, ninth decade of life and things like that. In terms of sort of racial and ethnic background, this should be taken with a little bit of a grain of salt, but there's some signal that possibly the cerebellar type of MSA is more likely to occur in people of certain East Asian populations, Japanese and Korean, as well as mestizo sort of Central and Southern North American populations. And MSA Parkinsonian type is more likely to occur in people of European and maybe North American populations, perhaps not entirely simply of European ancestry. So there are really few medications that are FDA approved specifically for treatment in MSA. And really the main one is droxidopa or Northera for neurogenic orthostatic hypotension, where MSA is specifically listed as one of the diseases that causes neurogenic orthostatic hypotension. But really our paradigm of treatment is to take a symptom and to really focus on that symptom and do our best to treat it. And most of that treatment is off-label. So examples of that are with slowness of movement or stiffness. We can use Parkinson's medications like carbidopa, levodopa. For neurogenic orthostatic hypotension, I have the asterisk next to droxidopa because that is an FDA-approved treatment for people with MSA. But as Dr. Caine mentioned, she tends to use midodrine initially, and part of that is due to efficacy, part of that is due to cost and accessibility. Fludrocortisone, pyridostigmine, agents like that. Urinary urgency, we can use sort of things like mirabegron or vibegron or bladder botulinum toxin injections and things like that. But again, these are all fairly off-label uses when we talk about MSA. And there are pitfalls to that approach as well. So thinking about using Parkinson's medications in multiple system atrophy, we know that certain types of dopamine stimulation can potentially be problematic. So what we'd like to see is maybe some improvement in rigidity and stiffness, which can often even be painful, dystonia, and slowness of movement. But, dopamine agonists, so synthetic agents that stimulate dopamine receptors, are well characterized in MSA to potentially induce a fixed, often painful pulling the muscles on top of the dystonia that maybe there is part of the MSA itself. So sort of a very kind of malignant, what we call dyskinesia. Levodopa itself is less likely to do it, but it's a possibility. And so we have to be very cautious, and we have to be cautious about how we dose it. More medication is not necessarily better. And the paradigm with all of these treatments is the lowest effective dose we can use for anything is the best. The reasons that this happens with the dopamine agonist and potentially or theoretically with levodopa is not entirely clear. And now I want to sort of switch to talking more about clinical trial phases and then move on to sort of where things are with MSA in that framework. So, we think about preclinical phases, and that's really before we get to kind of phase 1, phase 2, phase 3. That's drug discovery, testing in healthy animals, and then potentially starting to test in models of diseased animals. MSA is one of those diseases, as is the case with many neurologic disorders, where there may be animal models, but animals are not really known to get MSA. So we can have models of MSA, but really no animal has MSA. And then this is the phase in which there may be a patent applied to a new molecule by a drug company, a university, or some other sort of biotech. After preclinical testing, researcher, university, or drug company then submits to the FDA what's called an investigational new drug application. And basically what that does is it outlines what the future plan is for researching that agent in the setting of a disease process. What's the current research that's been done preclinically, how the drug is made, what the ingredients are, and the plan for clinical testing. And so before anything can move into a human phase trial, there needs to be an IND. After the IND, we move into the clinical trial phases. So phase 1 is safety. That's typically healthy volunteers without specific disease, really to test for safety, unintended adverse effects, things like that. And, in Charlottesville, like many other college towns, we have a large population of phase 1 volunteers in our undergraduate population who often volunteer for these types of things, and we get, good amount of safety data. Again, if there's a signal of toxicity in the animal models, it doesn't make it to phase 1, but humans and animals have certain differences in physiology. And so we need to, before we sort of expose people with a MSA to a new treatment that hasn't been used in humans before, it's safest to try it in somebody who's otherwise healthy. And then we move to phase 2, which is more related to dose finding and efficacy. So we find, okay, these doses are safe, but are the doses we're applying really likely to have a true physiologic impact? And this is important because we can have clinical trials that identify something, or preclinical studies that identify a treatment that potentially can have great promise. But if it's underdosed in a clinical trial phase, then we'll get a false negative signal that something doesn't help when it really could help. So this is critical. Safety is still the primary outcome when it comes to phase 2, because now we're moving into people who have MSA. So this is the setting of MSA. People who have MSA, there may or may not be a placebo control arm. Oftentimes there is, where there's a group that's on placebo, and then there might be a few different active doses, a low dose, a high dose, or a medium dose, to sort of see, okay, what is the safety difference between these different doses? And potentially, is there a signal of some benefit? Now, these studies aren't usually large enough and don't last for long enough to statistically show a difference between a treatment and placebo, but we can at least get a signal to say, hey, based on this, does it make sense, either from a safety or an effectiveness standpoint, to move on to a larger clinical trial? And those larger clinical trials are phase 3. So that's kind of what we think of when we hear the term randomized clinical trial or randomized placebo-controlled trial. So these are large, complex studies that usually are done at multiple sites, often multiple countries, where there's double blinding, which means that people that are participating in the study don't know if they're getting a placebo or an active dose of medication. People who are rating the participants in the study also don't know. So how this practically works is there's sort of a pouch that has a number on it. There's identical capsules, and a computer generates a random number and says, this subject will get this pouch, and the investigator opens the pouch, the research coordinator opens the pouch, gives it to the subject, the patient, and then they take that, and nobody at the site knows if that's the active treatment or a placebo. But then that key is transmitted for data analysis sort of throughout the study, partly to ensure safety, but then at the end to assess, sort of effectiveness compared to placebo for an active treatment. And after this phase, drug companies then usually apply after phase 3 to achieve FDA approval. So when we talk about something being FDA approved, it really has to happen after, rigorous comparison, particularly with placebo. And then phase 4 is what we call post-approval monitoring. So this is basically, there's an agent now that's FDA approved. It's usually commercialized. It's available for patients to use. And now what information are we getting now that it's available in a real world setting? Clinical trials, as many of you know, particularly phase 2 and 3 trials, have a lot of specific criteria for people to be eligible to be in studies, and can exclude a lot of people with other medical conditions. That can make sense when we're trying to really look at the effect of a certain medication on a specific disease. But when we get into the real world, all of us have other medical issues. And so we want to know, Are there safety issues that come about? Are there additional sort of signals towards effectiveness of treatments? And that happens in this phase 4 trial phase. And so now on to MSA pathophysiology. So we've talked about the clinical trial phases. We'll talk about our understanding of what causes MSA, and then that'll sort of be the segue into the rationale for some of the therapies that I'll sort of discuss in the last part of the talk. So, as Dr. Figari mentioned, the exact cause of MSA, or the causes really are not entirely well understood. But we think about this different cell types of the brain, and this is where MSA, that's often called a Parkinson's plus or a Parkinson's adjacent disorder, really differs from Parkinson's disease. So in the brain, there are two major cell types: neurons. These are the cells that kind of have cell bodies, and then axons that transmit electrical and chemical signals. So kind of, connect to each other, create pathways, circuits. And then we have glia, which are more, have traditionally been thought of to be support cells. They support neurons. They provide sort of brain homeostasis, both chemically, from a pH standpoint, things like that. And they have other functions as well, maybe some related to immune response in the brain and things like that. And one type of glial cell is an oligodendrocyte. And so as Dr. Figari mentioned, these cells provide myelin that kind of insulates the axonal or the neuronal axons to preserve electrical signals for cell-to-cell transmission. And it's these oligodendrocytes that we know are affected in multiple system atrophy, which is different than Parkinson's disease, different than dementia with Lewy bodies. And so at the root of what's felt to be the basis of disease in MSA is an abnormal accumulation or aggregation of alpha-synuclein protein in these oligodendrocytes. And this aggregation is kind of the pathological hallmark of MSA. So if we talk about diagnosing MSA from a definite pathology or post-mortem standpoint, this is kind of what's looked at by the pathologist to diagnose MSA with more definite certainty. And like I said, that differs from other diseases that we call alpha-synucleinopathies or synucleinopathies, like Parkinson's and DLB, in that those disorders have alpha-synuclein aggregation, usually in an inclusion called a Lewy body, which MSA doesn't have, and those Lewy bodies are in neurons as opposed to in these oligodendritic glial cells. So going into what are some experimental therapies in the pipeline, I'll start with one, ampreloxetine. And so this is related to an agent that's already available called atomoxetine. And it's being investigated to treat orthostatic hypotension in multiple system atrophy. And it works by increasing norepinephrine or noradrenaline in the peripheral nervous system. And that sort of, it blocks the reuptake of this norepinephrine, so more norepinephrine is available. That works to constrict blood vessels, and by constricting blood vessels, it increases blood pressure. It also may have some effect on increasing cardiac output. So it kind of helps drive the sympathetic nervous system to basically increase blood pressure, so that a change in position, for example, from lying to sitting or sitting to standing, we don't see as dramatic of a drop of blood pressure to potentially avoid, feeling faint or and having falls, or frankly passing out. And that's moved past phase 2 and is starting a phase 3 trial soon. So this is the one treatment that I wanted to highlight that's treating, again, a symptom or a feature of MSA, not treating the disease directly. The rest of them are targeting MSA itself. So the one of the agents that's probably fairly far along is amlenetug, and this was recently given what's called FDA Fast Track designation to expedite development. So basically, what that means is that the drug company and the FDA sort of check in regularly and far more frequently, and the FDA gives feedback on if this is what we're looking for potentially for an FDA approval, or these are the steps that we'd say, they kind of help with providing feedback on trial design so that the trials that these companies or this company is doing really achieve the FDA metrics. And if it shows benefit in achieving those metrics, then there's sort of a faster sort of assessment for approval. This is a monoclonal antibody, so a sort of immune type of molecule that binds preferentially to this aggregated or accumulated species of alpha-synuclein. And it does so not within a cell, so not within these oligodendrocytes, but rather extracellularly. So part of that mechanism that I didn't have a slide about, but I wanted to highlight, is many neurologic or neurodegenerative disorders, MSA included, the thought is that there's some toxic exposure, toxic change, and then there's a propagation of that toxic change to different parts of the brain that spreads along, different cell populations. And it does so by means of going from one cell to another, so through extracellular space. It's difficult to get sort of an agent to the brain, and then within the brain into cells, and within cells into sort of the part where our DNA is into the nuclei. But getting something more extracellular, particularly a larger molecule like an immunoglobulin, is more feasible than into a cell. And the thought here then is, if this antibody can bind to abnormally folded and clumped together alpha-synuclein oligomers, so short clumps of this alpha-synuclein, then that complex then is cleared away by sort of the innate immune system in the brain, and we prevent propagation of this alpha-synuclein pathology from cell to cell and slow or potentially even stop progression of disease. So that's sort of related to the prevention of abnormal spread or seeding between cells. And as I said, this complex is cleared by the immune system. The goal of this treatment is to slow progression of MSA, and it's an intravenous treatment that's applied every 4 weeks. There was a phase 2 trial called Amulet. It showed safety. It showed some signals of benefit, though not very strong signals of benefit. But again, it's not powered to do that. It's really there to show, is it safe? Is it clearly not harming people with MSA or accelerating disease, and then moving to a phase 3. So now there's a phase 3 trial that's underway. It's called the Mascot trial. And the primary outcome measure, how it's trying to assess, is there benefit for people with MSA, is comparing placebo versus active drug treatment using this unified MSA rating scale. So kind of, and this is the total score. So using both patient-reported symptoms, activities of daily living, a motor examination, to sort of develop a score and see if there's a difference between placebo and active treatment groups. The next agent I wanted to highlight is called ATH434. So whenever you see this sort of combination of numbers and letters, it tells you it's often in an early phase of treatment, because the drug company hasn't actually given a name or submitted a name to the FDA, even a generic name. And that process is a whole separate entity in and of itself, with focus groups and things like that. And I'm sure most of you know, if you can't watch the evening news without seeing a dozen drug company commercials or medication commercials, and all of them have names that may seem strange, but it's its own industry and kind of how to develop a drug name and what's marketable. But nevertheless, so this treatment is a little bit different, and what it does is it redistributes iron in the brain. So there can be abnormal iron deposition in the brain with MSA, which Dr. Figari noted. And this molecule is what's called an iron chaperone. So it sort of redistributes or accompanies iron that's deposited in the brain. And the thought with that is redistributing iron in the brain can inhibit further misfolding of alpha-synuclein, and thereby sort of prevent further aggregation of misfolded alpha-synuclein proteins. And again, the goal of this treatment is to slow progression of MSA, and it's a twice daily oral medication. And the outcome measure primarily is that unified MSA rating scale, but just part one, so the activities of daily living. It's completed phase 2 with results earlier this year, and the results were fairly positive, and so phase 3 is in the planning stages. TEV 286 is a small molecule that also acts, on inhibiting alpha-synuclein aggregation by impacting iron accumulation in the brain, and it's also an oral medication. The same goal and really the same outcome measure, to slow MSA progression compared to placebo, and it's testing that again with the primary outcome being looking at this unified MSA rating scale part 1. This is earlier in this phase of development, so this is still in phase 2 trial that's ongoing now. So not as advanced as the ATH compound. And then this ION 464/BIIB 101 is a joint sort of investigational drug between Ionis Pharmaceuticals, ION, and Biogen, BIIB. And this is what's called an antisense oligonucleotide. So basically, there can be a dosing of alpha-synuclein. Alpha-synuclein is a protein that we all have the gene for. We all have alpha-synuclein, whether we have MSA, Parkinson's, DLB, or not. As is the case with many proteins, we know what the structure is, but we don't quite understand what the function is. Alpha-synuclein is vital in development, both in embryologic stages of life and early life. What the role is later in life is less clear. But we do know, based on studies in Parkinson's of certain families where Parkinson's is very, sort of penetrant, where everyone in a family develops Parkinson's, that people who have mutations where they have extra copies of this alpha-synuclein gene greatly increases the chance of those people developing Parkinson's. So there's a dose-related phenomenon. The more alpha-synuclein, the more likely there's going to be misfolding and then development of these toxic sort of aggregates that develop. And so the rationale for this study is to say, if we prevent alpha-synuclein from being taken from a gene to a protein, so blocking that process using what's called this antisense oligonucleotide, we can basically reduce the amount of alpha-synuclein in people's bodies and brains, and thereby slow the progression of MSA. This is a treatment that's given intrathecally, meaning via the spinal fluid. So similar to a lumbar puncture, but instead of sampling fluid, there's medication given through that sort of cannula into the CSF or cerebrospinal fluid space. In preclinical studies, there's demonstration of a reduction in neuronal death, and alpha-synuclein levels were reduced as well in models where these cells were exposed to toxic alpha-synuclein fibrils, so already clumped, misfolded alpha-synuclein oligomers. Currently, it's in phase 1, and again, a collaboration between Ionis Pharmaceuticals and Biogen. Earlier this year, Biogen sort of had a press release where they talked about shifting their priorities, cutting costs, and said that they were ceasing further study on this agent. But Ionis Pharmaceutical seems to unilaterally be pushing ahead because it's still active on their website, and they've made no comment about ceasing study on this agent. So the BIIB 101 component may not be there, but the ION 464 name still lives on. Next, there's TAC 341, and this is another monoclonal antibody to alpha-synuclein. It's also delivered via intravenous infusions every 4 weeks. And the same goal, unlike the amlenetug, this is looking at just the part 1 of the unified MSA rating scale as opposed to the total score. And a phase 2 was completed with results just a couple of months ago. And it showed that it failed its primary and secondary objectives. It was shown to be safe, but otherwise didn't really show much of a signal to benefit. And so Takeda Pharmaceuticals, the company that produces this, has ceased further study in it for now. I wanted to talk a little bit about how to learn about clinical trials, but I wanted to go back to I believe it was Terry's question about about agents that we don't typically think of, like ibogaine or other sort of agents. So ibogaine is sort of, I think related to a botanical from Central Africa, has some psychoactive properties. And as the case with many sort of nutraceutical types of things, there's always been great promise about what potentially can it provide in terms of medical therapy. The most advanced, you know, use of things like ibogaine are more in psychiatric disease, mood disorders, maybe schizophrenia. And Dr. Dainton-Howard probably could talk more about that. But in terms of neurologic disease, there's some thought, oh, could there be promise in multiple system atrophy, maybe even Parkinson's disease? And it's available as a supplement, but often more available in the setting of, specialized clinics that sort of use this agent or other agents. When it comes to understanding what are both the safety and the beneficial effects of agents that are either supplements or are not kind of yet within the sort of clinical phase, trial phase framework, it can be difficult to know. I've heard or I've seen on Facebook, this is something that helps, or this is a miraculous treatment. And the answer is, we can't discount the promise of things that haven't gone through clinical trial phases. In other words, something that's not FDA approved can still be very much beneficial. But we also have to, I think, be open-eyed about what limitations are as well. And I think safety is important. So ibogaine, for example, can potentially cause cardiac arrhythmia. And that's fine. There are many FDA-approved medications that can do that. But that, going through the approval process, going through sort of preclinical trials, rigorous human studies are important more than anything else from a safety standpoint. And I also have plenty of experience with people with MSA and other diseases coming in and saying, hey, I feel terrible. And then I look at their medication list and they're on 50, supplemental or homeopathic agents. They said some of these are interacting with, the other. And so if we talk about, is something there to help with symptoms? Well, we'll know fairly quickly, is something helpful or not? But it's a much more challenging thing to say, could this potentially slow my MSA? Because we have a hard time really measuring that, especially on an individual basis. And then it can turn into, well, this thing could be helping. I don't want to stop it, but here's another thing that might help. And adding more things on can be burdensome, could be financially burdensome, but could also pose a safety risk. I think one thing that we have in the setting of our National Institutes of Health is a mechanism by which something that doesn't have a patent, so a drug company can't necessarily profit from it, provides funding and resourcing for investigating those types of agents. And that's a competitive process. There are a lot of people applying for research for funding and studies, but this is where having an aligned, research endeavor, whether, the NIH, with the FDA and Medicare, for example, make a big difference. Because if Medicare says, hey, if we had a treatment that's cheap and effective to slow multiple system atrophy, that would provide a lot of savings for our medical industry. That would provide a lot of benefit, certainly for patients and family members. A drug company may not profit from it, but this is where a priority could come in that would then guide both the FDA and the NIH. And that's happened. That doesn't happen as frequently as we'd like to see. But the discussion of things like ibogaine or other agents is really a good topic for people to discuss with their neurologist, primary care providers. Those are the types of things we like to hear about and discuss, because our interest is in what's best for our patients, the people we see with MSA, not related to, other factors. And I think that anything we can apply that provides benefit is something we want to have. So that's not a totally direct answer about Ibogaine itself, other than to say what benefit it has. If it's truly beneficial, then it should stand up to rigorous clinical study, and also stand up to safety testing. And that applies to many other things as well. As far as the next question, we're not a clinical trial site with amlenetug, so the answer is hard to say. But again, this is why there's clinical trial testing. So, again, if you go through clinical trial testing, then there's no, there's really, all the curtains are open, both positive and negatively. If something doesn't go through that phase testing, people can say anything about it, and then there's a disclaimer at the bottom that says this agent is not meant to treat or cure any disease or diagnose or treat any disease. And that disclaimer is not always sufficient to keep people away from things that could potentially be dangerous. So more information is always better about anything that we expose ourselves to. So going back to these slides, getting involved, learning about clinical trials is important. Probably the single best repository for clinical trial information is clinicaltrials.gov. That's hosted by the National Institutes of Health, but it doesn't just include NIH-sponsored clinical trials. Really, any clinical trial, mainly around the world now, registers with clinicaltrials.gov to give information about the nature of the study, the structure of it, but also contacts and locations. And so I encourage those of you not familiar with it to please check it out. And then the resources I have at the bottom are a little bit more proactive, registering or getting on mailing lists of Mission MSA, Cure PSP, and the Michael J. Fox Trial Finder. So the Michael J. Fox Trial Finder, we think about Michael J. Fox Parkinson's, but in the registration for being alerted to possible clinical trials, it's very clear about I'm interested in trials related to Parkinson's, MSA, PSP, and a couple of other disorders. So it's not exclusively for people with Parkinson's. And I encourage all of you to check out these resources. And I think we'll make these slides available to all the participants, and including, in addition to, of course, the recordings of today's sessions. And so the summary is, we don't quite understand the root cause of MSA. Could MSA represent multiple different possible disease processes that have a similar pathway with some autonomic dysfunction, Parkinsonism, cerebellar dysfunction? The answer is possibly yes. But it's clear, and it's become increasingly evident, and I think this is the major advance we have over the last decade, is that the accumulation of misfolded or misfolding alpha-synuclein proteins in oligodendrocytes is part of the disease process. Maybe not in its entirety, but certainly something that's a very negative development in the development of MSA. There's no proven treatment to slow MSA progression, but there are a number of investigations under various trial phases, as we've reviewed, many of which reduce alpha-synuclein production or aggregation. And staying active and finding clinical trials and participating is really the shared goal of people with MSA, family members, healthcare professionals. So it's really, I learn a lot from the people I see with MSA every time I see them, because they come back with, hey, I've heard about this, or I've read about this, and I look into it further and I say, that's something that we should really screen for or apply in terms of, a treatment or things like that. So that sort of concludes my talk, and thank you for the interest, and thank you all for being here and for sticking with us to the end of this educational day. It's something that I think we want to sort of make a regular thing, at least annually. And I'd like to highlight a couple of sort of points of appreciation before we get into the Q&A. The first is to Mission MSA for helping support this program and providing resources where we can have hopefully a seamless, live webinar, and I think it's really going well. Thank you to Peter for sort of making this seamless as well for us. And most importantly, I want to thank Alex King really organizing and putting this day together. Alex has really been a resource for our patients with multiple system atrophy, as a leader in our MSA and atypical movement disorders clinic, and really dealing with our group, and like many other groups, is like herding cats. So thank you for being persistent and putting on such a great educational event. And with that, I think we can start going through some of the questions. And so, what I would say is there are different ways you can ask. You can go through the Q&A, you can go through the chat, or you can even raise, I'm not sure, Peter, if we have the capability of guests to raise their hand, but Alex and I will sort of take turns kind of addressing some of the questions that come up.
And we did have a lingering question before from Snap about what symptoms really differentiate multiple systems atrophy from primary autonomic failure, which is one of the subtypes. And we were hoping if Dr. Figari was still able to comment on that, but he may be driving. So if so, Dr. Shah and I can cover that question.
Yeah, no, hi, I'm here. I'm not be able with the video, but I think that's a very good question. And when we talk about primary autonomic failure or PAF, really we're talking about all of these symptoms of dysautonomia that Dr. Caine was explaining earlier, but without the other characteristics of MSA that I was saying on my presentation about the clinically established or clinical probable MSA. So no Parkinsonism, no cerebellar dysfunction that is affecting the patient. So it's just the dysautonomia as the primary symptom. Now, in regards of the SYNC1 testing, as I pointed out, both patients will have this abnormal accumulation of alpha-synuclein in the skin biopsy. So not really a good way to differentiate one from the other. Right now, the main way we have is through the clinical syndrome. And I don't think that we don't know for sure, are we dealing with just same disease at a different stage or spectrum of the disease, or these are truly two separate entities?
Thanks, Dr. Figari. I think I just see in the Q&A, Candace asked about, we talked about, I focused more on kind of experimental therapies in terms of slowing MSA progression and things like that. But I think Candace brings up a really important question, which is studying the disease from sort of a comprehensive wraparound perspective. And the answer is yes, there are, studies that look at that. They often can be a little bit smaller, maybe a single site, maybe a network. It also highlights, I think, one of the challenges with rare diseases that we sometimes encounter, which is, if we look at diseases that are pretty ubiquitous, heart disease, stroke, there can be, larger networks that look at the impact of disease on disability, on quality of life, on family members, on society, and other features of disease. As diseases get more rare, that becomes more challenging to do, but it doesn't become any less, or it's not any less important, to be honest with you. I will share my screen, and this is just as an example, Candace, but I hope it's helpful for many people. So this is a trial that's recruiting. I don't know if you can see therapeutic education for MSA patients and their caregivers. Alex, can you see that?
I can, yes.
Okay, great. And so this is in Toulouse in France, but I think the key is that this is really more related to less about alpha-synuclein and how we treat symptoms and what prescriptions we apply, or even, physical therapy or occupational therapy, and more about what are the ways that we can educate people and families about MSA? What are the ways that learn about the ways that it impacts their lives? We interact with people in clinic in our healthcare system for 30-minute to 90-minute increments, and that's a small snapshot into the life of somebody with MSA or the life of somebody caring for somebody with MSA. So Candace, I wish I had a more comprehensive answer. The answer is yes, but not as strong of a yes as I think we'd like to see. And then SNAP, actually, let me just go back. So and just going back, Terry has some questions, and while we can't answer specific care questions, I think knowing what resources are available is important. Knowing what resources Medicare provides for veterans, knowing what resources the VA system provides, or retirement benefits with different potential long-term care, et cetera, coverage. Generally speaking, Medicare does provide some resource for ambulatory aids, walkers, wheelchairs, potentially motorized wheelchairs. What we may see is what Medicare provides is resources for something that ticks a box but may not be the most ideal, example. So all motorized wheelchairs aren't the same, but to sort of achieve the optimal type of motorized wheelchair as an example might lead to some out-of-pocket cost to supplement what Medicare covers. But Medicare does provide for what's called durable medical equipment, or DME equipment. And then just going back to Snap's question. So, we think about PAF as being kind of a mono system type of entity, which is the autonomic system. And so that's a very big system, and it causes a lot of different symptoms, whether it's related to blood pressure control, heart rate, variability, which is less of an issue in MSA than in Parkinson's, as Dr. Figari noted, but nevertheless, potentially worsen constipation, urinary urgency, erectile dysfunction. Those are all autonomic features. The difference there between primary autonomic failure symptoms that encapsulates what I just mentioned and multiple system atrophy is that MSA we define as being in one of these two categories, a cerebellar type and a Parkinsonian type. So there's a motor component where there's an impact of motor neurologic deficit, either similar to Parkinson's, what we call Parkinsonism, slowness of movement, rigidity, not usually tremor, but maybe some tremulousness can be present at times, or a cerebellar dysfunction, incoordination, imbalance with gait, frequent falls. That is in addition to autonomic dysfunction, whereas primary autonomic failure does not have those sort of neurologic motor features to them. And it can be the case where somebody is diagnosed with primary autonomic failure, develops one of these motor neurologic syndromes, and that diagnosis is revised to MSA. So I hope that helps Snap to better clarify. Let's see, what other questions do we have?
I don't see any in the Q&A.
All right. I don't see any additional in the chat.
Dr. Shah, one question on your presentation. When folks come across these studies or reports on social media or these different non-peer-reviewed websites, how do you counsel people to approach them? Do you encourage them to talk with the neurologist or investigate more on their own?
Yeah, I think, and this is both I think it highlights limitations that we all have. So, nobody has all the answers about MSA, right? And that's one of the first slides I said is we don't know exactly what causes it. Well, that's a frustrating thing for all of us, but especially for people that are dealing with MSA directly. So we don't have all the answers. And the other is that something that's not FDA approved very well can be helpful. So then how do we judge that? How do we approach it? And I think my approach is from a safety standpoint. Don't buy something online from who knows where, because then it doesn't matter what the bottle says. There can be mercury, lead, other stuff like that. So, okay, so the first step is let's assess safety. Is this something that we know the supplier, we know it is what it says it is? And then the second is to say, all right, does it interfere with anything that a person is taking? Are there potentially, unrecognized or at least unpublicized, risk? Things like cardiac arrhythmias can be common in many, many agents, both prescription and non-prescription. And then sort of creating a plan to say, what are we trying to achieve with one of these sort of over-the-counter supplemental agents? Is it trying to feel better? Is it trying to say, does this help my symptoms? Well, like I said, that's easier to discuss because we can say, let's give it a month trial. We do that with prescription medications quite often. If the thought is, well, I want this to slow progression of my MSA, that becomes a much more challenging thing to assess. And the worst case scenario, as I mentioned, is somebody just continuing to add more agents to their medication list, to where then the medication list becomes the burden in and of itself. So with that, the discussion is a lot about, if something is going to show benefit, then we sort of have to say, okay, let's look to see what's available, what's been published, things like that. The other thing I'd say is if, there's a treatment, and it's offered at specialized centers, even if it's discussed as a research trial, and this is a red flag for everyone listening, if you see something that's listed as a research company, a research firm, a research clinic that makes participants pay to be part of a research study, that's a red flag. Because then it really is starting to mix how much research are they doing versus how much money are they trying to make from people who are desperately seeking some sort of treatment that's effective. And in many ways, we're dealing with a vacuum because we don't have anything that we know is proven to slow MSA progression. So I hope that answers your question, Alex.
Yeah, that was a great review. Thank you so much. Let's see, anything else come in?
I think Snap asked another question about weights and walking regularly, kind of aerobic and exercise activity. I'll let you take that one, Alex.
Yeah, so so we know in Parkinson's disease with aerobic exercise, we can see slowing of progression of the disease compared to others that don't. In multiple systems atrophy, I don't know if I've read an exact trial on that, but what we do know is that people who exercise with aerobic exercise and weight training have less symptom burden compared to others that don't, especially when it comes to fall risk and then injuries that come out of that. It can help with fatigue, different mood syndromes, and can help with sleep. So from a quality of life perspective, you see this, substantial increase in benefit from both more so aerobic exercise, but the weightlifting portion, I think, is also quite helpful, which can help reduce the risk of fractures. But are you aware of a disease modifying effect in the MSA population?
I don't think it's been as well characterized as with, things like Parkinson's or even Alzheimer's. If we think about the mechanism by which things like exercise can be helpful, one is lifting weights can maintain muscle mass. And we know that, all of us lose muscle mass kind of when we get older than you are, Alex. So you have that to look forward to, but it's harder to keep muscle on, it's harder to build muscle. And so part of that is a factor of dietary protein, but also resistance training. And so that can help provide better ability to sort of counteract things like imbalance that can come with multiple system atrophy. So from that standpoint, it may not slow the disease progression, but may slow functional deterioration or delay disability or debility. And then aerobic activity, how it may be beneficial in things like Alzheimer's and Parkinson's, at least in what's been seen in both animal models and to a lesser degree in humans, is an increase in growth factors, neurotrophic factors in the brain. increased vascularization, so better blood flow, particularly to vulnerable areas of the brain that can degenerate in those conditions. And so if we apply that sort of rubric to MSA, certainly aerobic activity won't hurt and potentially can have some of the same protective effects as PD. As I mentioned, as we've talked about before, MSA is a much rarer disorder, so that body of literature is unfortunately never going to be quite as robust as with Alzheimer's or even Parkinson's. So there's a question, have you seen a subtype of patients that are affected more neuromuscularly than others, kind of like ALS? That's a good question. We think about MSA as being a syndrome that affects kind of our motor planning areas, what we call the basal ganglia, kind of learn motor activities, things like that. But it very much can affect kind of primary motor pathways. So that can manifest as reflex, symptoms start on the left side and the reflexes are kind of abnormally hyperactive or jumpier on one side of the body. We tend to think of that, we can see that in things like ALS very commonly with hyperactive reflexes. We don't necessarily see muscle weakness itself, though we can see it, especially the longer something like MSA progresses. But if there's slowness of movement, then as we define it from a neurologic standpoint, it's not true weakness, but from a symptomatic standpoint, it is weakness. So slowed movement, more difficulty activating a muscle, a longer time or a longer latency to generating 100% strength or 100% resistance, then that practically is weakness, right? And so I've certainly seen people who present with far more of kind of a muscle weakness type of presentation with MSA, as opposed to, say, a imbalance or something like that, at least initially, or difficulty swallowing. One thing I want to mention to all the participants is, please consider sending us your topic, preferences as we plan to do this again. One thing that I just thought about is, speaking of swallowing dysfunction and potentially, what we call respiratory stridor and multiple system atrophy is something that I think, we probably engaged our speech pathologist and maybe one of our ENT colleagues to come and talk about. But we want to talk about what you want to hear about when it comes to MSA. So please, reach out with topic discussion or topic suggestions now or anytime.
And I'll make sure my contact information is available for the Mission MSA folk to reach out with feedback or directly to me. So next year we can plan based on what the interest is of you all. And you're talking before about, do we include people from sleep and neurology? This may be a good medium to have those specialists come out and talk more from their perspective too. So that is something we could consider next year.
I think we'll give another minute, and then we're getting close to the hour. So, like Alex said, we'll make sure that you have a way of reaching out to us. And I also want to thank our speakers, in addition to those of you who joined as attendees. This will be something that's available, should be hosted by the Mission MSA website. So it'll be available to review and maybe generate even more questions. But there have been some great ones, so I'm glad to see that. All right. Well, if nobody else has any other questions that come to mind now, again, I want to say thank you for spending this frigid Thursday afternoon with us. And thanks again to Mission MSA for helping support our ability to do this today.
Yes, thank you all so much. Well, perfect. So Peter, anything that we need to do on our end, or okay to close things out now?
we should all be good all to close things out.
All right. Well, thank you everyone so much for coming and spending the afternoon with us. We look forward to your feedback, and I will get this recording out to the Admission MSA people so they can post it on their website, which I think will be easier rather than us sending it out directly.
Goodbye, everyone. Thanks for joining.